All right, everybody, 6 o'clock on a Thursday. You know what that means. This is Matt from Trumbull Regional Medical Center. I got Larry here in the command center with me for our education tonight. Tonight we have a couple of guest speakers that we're really looking forward to. Tonight we have Natasha Kramers. She's a counselor and employee assistance program coordinator with Meridian Healthcare. She's going to be talking to us about all the crazy stuff that happens to us and how to take care of that, how to deal with that. And we're looking forward to that. We can use some help with that. Afterwards will be Dr. Michael Cafaro. He's a chiropractor and team physician with Weathersfield Local School District athletic teams. And he's going to be talking to us about sports injuries and the interaction with physicians and EMS on fields and athletic trainers and some of those questions and stuff. Following that, we're going to have our very own Larry Monero. Everybody's familiar with Larry. Larry's going to be doing some case studies, some geriatric case studies that actually should be very interesting and interactive. So we're looking forward to that too. Just like everybody else, our COVID numbers are coming down. Today was the lowest we've had in, I don't know, seems like 5 years, but lowest we've had in a couple of months. We're down to the single digits, and I can't remember the last time I saw single digits. So that's pretty awesome. But you know, just as always, I always ask everybody, you know, still keep it up with the PPE, keep it up with, you know, doing the right thing for yourself and your patient and your family and everybody you work with. And so we can keep this stupid crap in check, because that would be a real big help. Other than that, we're going to get started. I see Natasha's ready to go. She looks like she's chomping at the bit, got a bunch of information for us. I've never met Natasha. Hi, Natasha. It's nice to meet you.
Good evening, everybody.
And the floor is yours, Natasha. Thanks for coming.
Thank you so much all for having me. I'm so appreciative of it. I was joking with my dear friend and colleague, Dr. Michael Cafaro, who's on the call this evening. Number one, that he could not heckle me like the two old guys on the Muppets tonight, and that I would be the serious one and he will be your comic relief for this evening. So I'm going to try to share the screen. And please let me know if I have difficulties or you do not see it for any reason. And please, it says to browse my computer, so I'm going to try that. And nothing doesn't work until you need it to work, so I apologize. Okay. Should be sharing it or working on it.
Not yet. Oh, wait.
It's trying.
We're all set.
Okay.
We're looking at your PowerPoint now.
Okay, wonderful. Again, like we mentioned, my name is Natasha Kramer. I am the main counselor and the employee assistance program coordinator for Meridian Healthcare. Again, thank you for having me this evening, having me into your offices, into your homes. Is it still working well?
Yeah, you're loud and clear. You're fine.
Perfect. I'm just frozen on my end. So anyways, I was going to give you all a little bit of background on myself. I'm a very informal presenter. So please, at any time, if you have something to add, if you have a question, if I say something that maybe you wanted more information on, please do not hesitate to unmute yourself, raise your hand. And I think some people from the chat some people will be monitoring the chat. So if you drop something in there, you have a question, maybe you'd rather just do that, feel free to let me know. Like I said, I'm very laid back about this. So a little bit about myself. I received both my bachelor's and my master's from Youngstown State University. My bachelor's is actually in forensics and criminal justice. I originally wanted to go into the FBI, but I am here now, so we see how that worked out. And my master's degree obviously is in counseling. It specializes in mental health and substance use counseling. So two-timer at YSU, and then I actually began my counseling career, both my internship and the early years of my therapy at Meridian Healthcare here, but I was actually working in our medically assisted treatment department. So individuals coming every single day to dose are required here to see a therapist, at least to do some case management and check in on them. So we have a minimum of 1,200 individuals on our MAT program. So obviously our counselors have a very large caseload. So that was where I started. But my love was always for individuals and working with employees. So I actually ended up leaving Meridian for a period of time, and I went to work in Euclid outside Cleveland and work with employee assistance programs specifically, and had wonderful opportunities there. Ended up coming back to work at Meridian, and now I work mainly in our employee assistance program. The alphabet soup at the end of my name, which usually only counselors care about or understand. I'll give you a little bit of a background on that. So I am a licensed professional clinical counselor. They let me supervise people. That's what the S means. Also, I am a licensed independent chemical dependency counselor, certified employee assistance program, what do they say, professional. Sorry, make it sound very impersonal, but even we forget what we have anymore after this point. It's basically just a lot of money. And then the Department of Transportation qualified substance abuse. So the Department of Transportation allows me to work with individuals who work on the railroad, who drive the big rigs, things like that. Also, the thing that I enjoy the most is probably my work as a critical incident responder. So I am a member of our Mahoning and Trumbull County Critical Incident Response Team. So when there is a trauma that is experienced by really anyone in the community, it could be a police department, it could be a fire department, it could be an EMS provider, whether it is something, a hospital system, whatever it might be that is beyond their norm, that is something that rocks their team to the core. They call in an outsider to help someone and to just kind of debrief. Some of you may have been part of a debriefing in the past. I didn't really know what critical incident debriefing was. I grew up in a family of addiction, and so I just kind of always thought it was just being a part of a family was putting out fires all the time. But then I kind of went to school and realized, oh, they actually have a name for this. It's called critical incident debriefing. And so if anyone is kind of an adrenaline junkie, this is how I get my adrenaline out, really, is by responding to these incidents and giving back to you all who give to our communities all the time. So I think someone might have their mic on, or if someone was saying something I missed it, I apologize.
I think I left my mic open. I'm sorry.
No, you're good. I just wanted to make sure you didn't need me to do something. All right, so that's a little bit of background about myself. So obviously what we'll do is, these are just the high points I hope to reach. So I hope you can walk away with something that is a little bit interesting for you, or something that maybe you didn't know, but just talk about the risk factors for first responders, what exactly you all are up against. And I did pepper in some statistics about other individuals in first responding. So I do have some firefighter statistics in there, a few things about police, but a lot about EMS, EMTs. So just kind of see where you are on the spectrum of things. And then just look at what makes you in particular as first responders more emotionally vulnerable than maybe the rest of the population might be. What puts you at a higher risk, and how to provide a little bit of mental health first aid, not only to yourself, but maybe to colleagues if you notice they're struggling. There is an actual trademarked mental health first aid curriculum. I do like to mention that I will not be following that particular curriculum when I refer to mental health first aid. It's just the stuff you all can maybe try to do a little bit more to help take care of yourselves. That's what I mean by it. So no confusion there. And learn ways to help support one another, see what resources are out there. And like I said, please, you are all the experts in this. I just have been given the honor of just touching on a few things this evening. So please, if you know of resources that you would like shared, Again, unmute yourself, put your hand up, drop something in the chat. I'm always looking for new resources to share with individuals that I work with, so please help yourself, do not be shy. Because I am a therapist and nothing makes people more uncomfortable than when I say I'm a therapist. It's usually the most quickest way to get crickets in a room. But I have to do my little therapy spiel right here where I just remind people that if we do talk about something tonight that is difficult for you, I know you all deal with things that are much more difficult than this on an hourly basis. But if for any reason we talk about anything tonight that is too difficult or that you really don't feel comfortable with, maybe I do encourage you to please step away, to just pause for a second, mute me, and just take a breather for a second, get a glass of water, and come back when you feel you're good to go. So I just always like to let people know about that. I don't want anyone to be triggered or feel like they have to sit here when they're struggling. So it is estimated that 30% of first responders will develop a behavioral health condition during their time of service, including depression, anxiety, post-traumatic stress disorder, PTSD, compared with 20% of the general population. So you all are obviously at that increased risk. Again, when we look at that, I always say it is not normal to do the job that you all do, and I mean that in a compliment. It is not normal to see the things that you see at a minimum of 12 hours every single day and not have that affect you and not have that absorb into you, into your soul, into your mind, into your heart, into your body. And so when we look at everything that you are all up against, of course, you're going to be at a higher risk. And again, I even say it for providers in our field, to hear the things that we hear, to see the things that you all see over and over again, the worst of the worst usually, the things that quote unquote normal people do not experience every single day, of course you're going to be more vulnerable. The National Survey on Drug Use and Health revealed that up to 29% of firefighters engage in alcohol abuse, and as many as 10% of firefighters may currently abusing prescription medication and prescription drugs. They do put prescription medication into prescription drugs, so they put that in the same class. So obviously higher with the substance use. Again, people need things and ways to cope, and we don't always lean on the things that are the easiest and the most healthy for us. We lean on the things that we know get results, and usually that is drinking. Usually that is the unhealthy thing, is the eating, the emotional, trying to help emotionally soothe ourselves. According to SAMHSA, 36% of EMS workers suffer from depression, 72% of EMTs suffer from sleep deprivation, and more than 20% of EMTs suffer from PTSD, all of which puts them at an increased risk for substance use. So you have this combination really priming the gun for substance use. All of it is the perfect storm. And when they mention sleep deprivation, which I know probably many of you either have right now or are coming off of, one reason they mention that so frequently when we look at statistics and when we look at factors that make first responders the most vulnerable is because sleep is our body's and our brain's chance to put things away in a way that makes sense. So what I mean by that is if you think about your brain at night as a filing cabinet, everything that you've been through throughout the course of the day or whenever you're sleeping gets put into files so that the brain makes sense of it, especially with everything that you all see in one single period or one single shift, and a lot of things that don't make sense and go beyond the norm. And like I said, what quote unquote the normal people, the average person, sees every single day. So the brain has to work extra hard with you all to figure out what you saw, make sense of the world, and then go back out there and do it all again the next day. And so when a person doesn't sleep, the brain doesn't get that chance to put the files into the correct files and then put them into the filing cabinet. Everything gets jumbled. If you know anyone who you look at their desk and they say it's organized chaos and papers are everywhere and files are everywhere, imagine day after day after day after day of that and more papers compiling. That is what happens to the brain when it does not have the chance to recharge in the evening or in the middle of the day or whenever they're able to with sleep. they're working on that constant deficit. And so that is a huge risk factor for substance abuse and also a huge risk factor for PTSD. Rates of binge drinking and heavy alcohol consumption are significantly higher among firefighters than the general population. And drug abuse is much higher among paramedics and EMTs compared to other emergency responder professions. So even higher than they would consider firefighters and police, the drug use is higher. Again, when I looked at the research, they cited the access to drugs is a lot easier, but also what you all are being asked to do every single day. Be up for a minimum of 12 hours at a time, sleep as little as you possibly can, and go from sleeping to jumping up and responding to a critical incident or to a call within 15 seconds. When I was doing some research for you all's presentation tonight, an individual said, for me to be falling asleep and then to be back up in a matter of 10 seconds, putting on gear, getting into the truck and getting ready to go and respond to something, most people don't have to do that. And they were right. Most people don't have to do that. We have that ability for a lot of us to wake up very slowly, to get acclimated to our day. You don't have that. And so even just the way that you're having to operate and work puts you at that greater risk. A little bit older of a study, but still kind of impactful. Again, not specifically for EMTs and EMS, but just kind of shows where we get the culture of how we cope with our jobs. So a 2010 study of police officers working in urban areas found that 11% of male officers and 16% of female officers reported alcohol use levels that we would deem as a counselor at risk substance use. And also, when they looked at why people do it or why officers do it, one of the number reasons was just to fit in, to be like everybody else. And 25% said a police officer report drinking to be part of a team, to be next to a person, to go out and have a bite to eat and have a beer. A lot of individuals I've worked with, when I ask about drinking, especially first responders will say, yeah, I drink, I don't really enjoy it. It's not really, my thing. But, when we're going out and we're talking, or when I'm out with other colleagues, it's what we do. And so that's very common. It's a culture in a lot of occupations. And a recent study by the Rudderman Family Foundation found that in 2017, more firefighters and police officers died by suicide than in the line of duty. And the same study found that post-traumatic stress disorder and depression can be almost 5 times as high among firefighters and police than the general population. In 2009, a study on the comparison of public safety provider injury rates found that EMS practitioners are more likely to miss work due to an injury than those in either fire or police services. So you all are even more, not even emotional injuries and mental injuries, but you're even more at risk for physical injuries. Just the way your work requires you to work, how physical of a job it is, opens you up to even more injuries for yourself. And then again, when we have individuals who are taken off of work or out of work because of an injury, comes along with that, I can't be at work, I can't help out, the guys and gals that I work with. And then we feel that sense of depression will start to creep in for people, anxiety, wanting to be at work. Many people develop their work families. You're with these people sometimes more than your actual family, with your coworkers. We all kind of share that dark humor with one another, and we love each other and care about each other. And so when we're not able to be there and we think about, I know this person has to work extra because I'm not there, we bring a lot of that guilt. And like I said, the anxiety and depression can start to creep in when we have first responders who are off of work. It's even sometimes more detrimental than them being at work, is not being there. Trauma is a word that especially we as counselors throw around a lot. But I always like for everybody to be on the same page as what we're talking about actually when we say trauma. So trauma is just basically that distressing or disturbing experience. And I always like to say that trauma is in the eye of the beholder. I could go through something and I could share it with someone else and they could say, oh my gosh, Natasha, please come on. That's not a big deal. I've been through way worse, or I've seen worse on a shift. Let me tell you about what I've been through. And we'll kind of do that war storying a little bit. But as a therapist, as a provider, if someone considers something traumatic, we don't question it. It could be that they killed a fruit fly yesterday. If they consider it traumatic, we do not question it. We go by their definition of if this was traumatizing to them. So when I work with someone, I always say, is there anything that you would consider traumatic that you still think about to this very day and you have a hard time forgetting about? Is how I like to phrase it. Also, too, when we think about trauma, we categorize it into two categories. There are big T's and there are little t's. T is in Tom, if I'm not coming across very well. But when we think about little t's, we're thinking about acute experiences over the lifespan of a person. And they add up, right? They're kind of like notches that are in a person. So you could think about job loss. You could think about a breakup, a very difficult breakup for a person, or a divorce. You could think about passing of a loved one. Again, maybe even though it was expected, it was difficult. And then when we talk about, but those, like I said, those do add up. A person can have a lot of small T's in their life. They've just been through a lot. Large T's are the things that you think of as the Hurricane Katrinas, the 9/11s. A very common big T for a lot of individuals is the death of a child. Again, doesn't matter the age of the child, but a death of a child and something that goes against the natural order of things. That's why for many individuals, the passing of a child is very, very difficult. And when we're working with someone, you usually know if you hit a big T versus a little t by the reaction in a person. So when we're working with someone and we kind of ask about these things, they'll be able to go through the small T's in their life without much change to their body language, without much change to them emotionally. They'll talk about, grandpa passed in around this time and this is what he passed from. And then, I started to work at this place because I got fired from this place, or, I resigned and it was hard, but, I made it through. The big T's for people are the things where you start to see the shift in body language. The tears will well up for people. I like to say it is that huge rock that the rest of their life has kind of happened around. And again, this can be whatever it is for that person. For many individuals that I work with who are first responders, they're amazed at the things that they struggle with. And I don't know if that makes sense to anybody, but I'll explain it a little bit more. So when I've had the opportunity to work with people, they have said, and it's been more often than not, they'll talk about their career as a first responder and all of the things that they've responded to. I went to this and I dealt with this. And as they're describing it to me, these are incredibly horrific things that they've dealt with. And again, they're describing them as very small T's. But then there will be the one thing, whether it was recent or they remember the date usually, they remember where they were, the time of year, what time the call came, and you almost see them go back to that moment in time and they'll say, I've dealt with all of these things. Why was this the most difficult for me? It wasn't even my worst call. And that sentence, I can't tell you how many times I have heard, because oftentimes for first responders, it is not what gets them or what they struggle with isn't always the worst thing they've been through. For many first responders, it's what they would consider one of the things that isn't a big deal, that I've been to before, but something makes it different for them. Whether it is reminds them of someone that they know, reminds them of their own child, reminds them of their own family, of themselves. Sometimes it can be even where that person is in their life. It's a perfect storm for them, right? They might be going through a divorce at the time. They might be having problems with their children. And then this call is the one that they struggle with the most because kind of the gun has been primed already with everything else going on around them. So we see a person who will eventually come talk to us or talk to their coworkers about things. not because it is the worst of the worst, not because it is the most severe, the most tragic, the most disturbing thing, but because there might have been other things that got them to that point, if that makes sense. So why are first responders so primed again for that trauma response and for things to be so impactful? Again, lack of sleep. I'm going to sound like a broken record this evening, but when you have no sleep, little to no sleep, and it seems like the same day for the past month and a half, the brain can't think as quickly, it can't put things back into the file folders, and things that might have been little deals are now huge deals for a person. The change in a shift, working with a different coworker than they originally thought, a call where a person they think has an attitude now becomes a much bigger deal because they haven't slept. And again, the second thing mentions they're probably not feeding themselves very well. They're probably not eating the way that they need to. We grab really quick things when we need to work really quickly, and those things are not always the most nutritious. And if they have been on a bunch of different calls in that short period of time or long period of time that they've been working rather, you have all of these previous traumas that have set this person up to be more impacted by the depression, the anxiety, and set them up for experiencing PTSD symptoms. That acute or chronic doesn't matter. It could be either. It could be long-standing or it could be very short periods of time, to both direct trauma and secondary trauma impact a person and a first responder to be traumatized and experience those mental health or substance use symptoms. And again, that secondary trauma, it's like what we think about as secondary secondhand smoke. It does not have to be that you are the one experiencing the trauma. It can be that you are getting onto a scene and you are talking with a person who has experienced the trauma, and it is like you are there. We oftentimes get that in the mental health field after we have worked with individuals, many, many years who have gone through very traumatic, distressing, and disturbing events. And we almost soak that in too much, where it feels as though we have been through these things as well. Compassion fatigue. I always say you can only care so much for so long. The well is not endless. It has an end. And when you start to feel yourself, I almost don't even describe it as getting burnout, but when you start to kind of feel crispy around the edges, it can make us more susceptible for anxiety, for depression. And compassion fatigue, again, you all have to care a lot when you go out there to take care of people, to respond the way that you need to make sure the job gets done and make sure that you're helping people. And we run out of that. Sometimes we go to places and we just have to really struggle to care, to want to help, because sometimes, again, the well is dry. That's not abnormal. We can't care all the time, every single day. It's not doable. All of those things collectively, like I mentioned, the compassion fatigue, the burnout is the stage that we get to really where compassion fatigue has taken over. We're past crispy. This is the point where we don't really want to be at work. And you can get burnout from a lot of situations, but I'll just reference work. We don't really want to be at work. We avoid it. We're driving there and we're dreading it. We're saying, oh my gosh, I hope something happens where I don't have to go in today. Not wanting to do the documentation, not wanting to see people, not wanting to go on calls, dreading when the phone rings. Those are all big red flags for burnout, and especially even the preemptive ones of compassion fatigue. The acute and chronic stress levels, all of that lead to that increased risk, especially for suicides among first responders. That rate is going up. And again, many barriers that we will talk about in the next slide that contribute to what keeps first responders from getting the help that you all very much deserve. In 2013, 69% of EMS providers reporting never having had enough time to recover between traumatic events. I don't know if you all feel like that's accurate or not, but many people say, I do not feel as though I have the time to catch my breath from one thing to another. My mind might still be on the call that we got previously, and I'm on another one. You know, I haven't even processed that one. I haven't even thought about what that was like and what I just saw. You know, you all see, I couldn't imagine what you all say. I'm not even going to try to describe what it might be like for you in a day. You all know. But even trying to describe that to another person, you know, the rest of us are sitting here with our eyes wide open, shock and awe. And this is a normal day for you all. So having that inability to be able to bounce back. And we know that resiliency, that ability to move from one thing to another, and recharge is what helps people the most with trauma. But if you're never given that opportunity, of course, things are going to be more traumatic. Any thoughts so far, or anything anyone has any questions with? I talk in this language every day, so I apologize if I'm going too quickly, but any thoughts anyone might have or anything that sticks out to you? Okay. I will keep moving.
Natasha, I missed your question. What did you say?
I was just saying, is there anything that sticks out to anyone, or anything that anyone finds interesting so far, or that questions on anything?
Honestly, I find a lot of it very, very interesting. Where my office is right by the EMS room, and these are a lot of the things that we talk about. Honestly, that I try to warn some of the younger guys about, you know, you think working 120 hours a week is normal, and it's not. That sleep deprivation is so bad for you.
Yes.
And I always tell them, you know, what's the first thing they do when they're going to interrogate somebody or brainwash somebody?
Yeah.
You soften them up with sleep deprivation and letting them fall asleep and waking them up. And we do it to ourselves.
Yeah, no, absolutely. And thank you so much. Yes, you get into a field where this is a requirement of the job, right? And then you ask you all to make life-changing decisions in a split second to help people, and expect these decisions to be perfect every single time. And
Right.
so I could not agree more. Yeah, thank you.
I see a hand up with Eric Metz.
Oh yeah, please jump in.
Hello, can you hear me?
Yes.
Hi. This is our department. I feel that's probably the biggest problem that we're facing right now is losing guys to mental health. And I think this is probably the biggest problem that's going to come for us in the future. I don't know if it's a generation thing, but we've lost more guys other than people leaving the department due to this type of issues than anything else. And I do think that your numbers as far as drug abuse and alcohol abuse is probably a little low.
Oh, I agree with you. Yeah, they're probably on the modest side. Yes.
Yeah. So. All right, that's all I got. Thank you.
Thank you so much, Eric. I appreciate that. No, I completely agree with you. I think that this is that unhidden condition, right? We know about blood pressure problems, we know about heart problems, we know about diabetes. We can see that. You can't see mental health usually. And especially certain people are very good at hiding it. And I am sure many of you are those people, because you have to be strong to help other people. You have to be there for everyone else. A lot of times you are at the back of that. And so we put on that very hard face to get through work. But underneath it, we are dying. And I thank you so much for sharing that. Yes, absolutely.
I'm sorry, one more thing. I think it's up to administration also to be aware of this, because I feel that a lot of departments don't even consider this. I know I see it all the time with a lot of guys, and you know, they have personal issues going on with their home, and all kinds of things. And it seems like they don't consider that. Just, you know, and plus, with the pressure of the job itself, just, you know, because everybody's worried about making a mistake and ruining their job or something like that. It's a stressful situation for a lot of guys. Oh, especially now that there's some more demand on what we have to do.
Yes, yeah, and you're under a microscope all the time when you're doing it, right? Because everybody has access to record you, to video you, to go onto the internet and either praise or critique how you responded. So yeah, you're absolutely right.
Okay, thank you.
Oh, thank you very much. Yeah. Yes, please, anyone. I agree with you. It is up to administration. It is up to departments to want to see this problem. You know, a lot of times, Bill, Give me one sec. A lot of times administration does not want to see it. They don't want to look that direction because what it might mean for them and what it might entail. Bill, go for it.
Hi, I think the other big problem with that is sometimes the individual of not wanting to say nothing at all and knowing that they need the help, but
Yes.
don't know or are afraid to activate getting that help.
Yeah, I agree with you. What do you think it is that keeps, and other people can jump in, but what do you think it is that keeps them from wanting to say anything?
I wouldn't say that it's so much peer pressure, but I would say it's more like, well, I'm a tough person. I think I can suck this up and keep going.
Bill, I think you read ahead in the presentation because yes, you were right.
No, it's just all the years of experience between
Yes.
fire and EMS. I got 42 years wrapped up in it. So,
Oh my gosh.
you
Thank
know,
you for your service.
Thank you, ma'am.
You're welcome. No, yeah, you have probably seen this play out every single one of these. You know, that culture and the suck it up mentality, right? If you didn't go into this to go through this, you know, this job probably isn't for you. Bill, go ahead.
That's all I had. I put my hand down.
No worries. Yeah, the perception of being weak, the perception of not being tough. You know, how will I be looked at if I say something? Many people are afraid that if they mention something, they're going to be looked at as they can't do their job. They can't cut it, right? This field wasn't made for, you know, for this kind of behavior. It wasn't made for being sad or depressed, you know, for struggling with your own mental health. You know, we're here to help other people. And that stigma, that culture and that stigma of we're tough, again, the perception of being weak. I always say, I know this is easy for me to say as a counselor, but there is a lot of strength in being vulnerable. I don't look at it as weakness. I look at it as vulnerability. And your all's career is built around not being vulnerable. And so to break through that is incredibly difficult. Confidentiality. This kind of goes back to what Eric mentioned about coming from administration. Sometimes there has been a perception that what an individual shares, or if they reach out for help, and Bill, you might have seen this in your years of experience, is that some things are not kept confidential. You know, some things are shared when they need not to be. Or a person makes a comment to someone in the department, and the next thing you know, it's in the company newsletter. Just joking, but you know, it gets around that quickly. And so also the knowledge, this again comes from administration. A lot of individuals I worked with didn't even know that they had programs available to them because nobody ever talked about it. It was a pamphlet that was old and yellowed around the edges and buried under someone's desk, and they never knew about it and they were never told about it. And when they find out about it, a lot of them will say, I could have had so many people I could have sent to this program. I didn't know about the program. I didn't put, one of the programs is obviously in my work is an employee assistance program, but I will tell you, a lot of people do not have a good experience with those. Yes, Ralph. I think someone might have had their hand up.
Yeah, that was me. Sorry, I was fumbling with the thing, but I did have a question because kind of on the account of management, what kind of suggestions would you have for like toxic management or not so good management to get on board more with helping people? For instance, we've brought literature up to our managers about like sleep deprivation and things that can be done as far as utilizing downtime better to kind of help out in that nature. So, and it basically just got pushed to the side of the desk and we were told to suck it up. So any suggestions on how to maybe approach that or get management on board better?
Yeah, well, first of all, I'm sorry that that was your experience and it really contributed to the barriers that we're talking about here tonight. But I think when you speak to and I find this in my area as well, you sometimes have to speak to what speaks to them. And what I mean by that is if they're concerned about people not doing their job well, if they're concerned about not retaining people, if they're concerned about, getting jobs done as quickly as possible, whatever their main concern is, I would really speak to why what you're sharing with them is going to help that. So for example, when I go out and I talk to companies and I say about employee assistance programs, and they probably do the very same thing as you experience, where they say, yeah, our employees just have to suck it up because, you know, this is why, and they have to leave their problems at home or whatever it might be. I try to speak to money and their bottom line and what I know they will respond to, and try to explain to them why having this will help them in other areas, why having this downtime will actually lead to less call-offs, why having this will help these other things that you do know that they care about. And sometimes it may just be that that person was told many years that they had to suck it up, and why should anyone be any different? And unfortunately, that is a lot more difficult to deal with. But I don't know if that made a little bit of sense for you, Ralph, at all.
Well, yeah, that made sense, because basically what we were told was that this person was old school and that's just the way it was going to be. Mm-hmm. When all the things you said were in the literature, you know, that we were presenting. But yeah, I don't know. It's just, it seems more like kind of looked at like the fire department now. It's not professional to be able to have downtime where you're either resting or napping during the day because it's work time hours and the public can see you, versus you're going to be up all night. You need to be sharp at night too. And that could be 20 hours from now. So absolutely, what's going to be better, to get the sleep or the downtime when you have it to utilize it properly to stay sharp, or to just drag it out and hope maybe you rest later, which probably won't happen.
Mm-hmm. Absolutely. And hope that, you know, and if a person's old school and they're concerned about their reputation, and I apologize, I do know somebody had their hand up. I will not forget about you. You know, maybe there is a concern about how their department's perceived and their reputation. And, you know, if you're expected to make very quick, good judgment calls on very little sleep, the likelihood of you being able to do that is minimum. And it gets worse and worse the less and less sleep you have. So I almost see you needing the sleep and the downtime as a requirement of the job to perform the job duties. So maybe it's even, you know, kind of the perception of reframing it that way. But I completely understand where you're coming from with, I go up against similar things in a different capacity all the time with the old school thinking. Yes. Thank you. Thank you for sharing with me. I apologize. I don't have a perfect answer for you. I wish I did.
Oh, that's okay. Thank you. I appreciate your answer.
Oh, absolutely, Ralph. I believe I missed another hand, and I apologize. I don't want to let anyone go without chiming in. Yes, Justin.
I found working in private sector and now in the public sector. Private sector.
Oh, I'm having a hard time hearing you.
Oh, I'm sorry. Private sector, it was dismissed a lot more than now that I work in the public sector. Private sector, it was the bottom dollar counted. Like, you had to take that trip no matter whether you been up, ran 5 horrific calls and 2 o'clock in the morning you hadn't slept. Well, you better get on the truck and go because we got to make that trip money. I also didn't want to like back you with like, because it costs them money to bring. Now that I'm in a lot more prevalent, but I think private EMS, there's your bosses are always after, you got to take that trip. We don't care.
Yeah.
We got to make that hard to get over that. Private sector, it's a little easier in the public. I think there's a lot more support there, but in the private sector, I think the support is there as much. Ultimate goal there is the money amount. Drive to your employees getting burned out quicker and not getting that investor.
Absolutely. Thank you, Justin. So what I heard you saying, if I heard it correctly, and if I missed anything, I apologize. It was just for audio's sake. Just that, like you said, the huge difference in the private versus the public sector, needing to make that money private in the private one, leading to more burnout, having that little bit more support, at least in the public sector as well. So that huge difference. But I'm sure, like you said, that was a big change for you to make.
Yeah. It was always, you know, public sector, if you were a little burnt out or you had they would help you try to navigate around that. In the public and private sector was like, well, we don't have another crew to take
Yeah, we need you to do this.
Yeah, that's all.
Oh, thank you so much for sharing. I appreciate that and for bringing out that distinction I wasn't aware of. Thank you. I think there was another hand.
I believe they took it down.
Okay. All right. Well, thank you all for speaking, for bringing more voice to this slide and for making it come to life. I try for these reasons not to be death by PowerPoint. And so thank you for letting this have voice from you all, like I said, who are the experts on this. Like I said, chime in anytime. And thank you for the feedback. I love it. Again, like you all mentioned, and one of the last few that I wanted to bring attention to was, first of all, finances. A lot of first responders are concerned, can I afford even care if I want it? And then the access, the hours that you all work, trying to find a counselor or trying to find an EAP provider to see someone at 2 o'clock in the morning. I'm going to be honest with y'all, that's a little bit of a tough call. I would probably have my own reservations about seeing someone at 2 o'clock in the morning. But again, that just speaks to the inability to get access to the services you all deserve. And honestly and candidly, not a lot of providers in my field understand the specific challenges that you all face all the time. Unless you go out and you actively seek education in it and you want to learn and you want to be knowledgeable of your culture and your field, you're not going to have it. You're just not going to. I've heard horror stories, unfortunately, of providers who have not gained that extra knowledge, not become aware of cultures, and who have acted in unprofessional ways and said incredibly unhelpful things to first responders. And it keeps you all away from our field. It keeps you all away from getting help. And on behalf of my field, I apologize if any of you are one of those people who have had a poor experience. So I apologize. It even says in 2016 that 52% of respondents said they actually did feel really comfortable talking to their coworkers about having a hard time. But just a slice below that, almost cut in half at 48% said, no, absolutely not. I'm not going to share. I'm not going to talk about it. It's going to become a big deal. Or like we spoke to earlier, like Bill said, I'm going to be seen as weak, so I'm not going to share this. Some red flags to look at when we are talking about whatever it might be. This can be for all of them, right? This can be for substance use, this can be for depression, this can be for anxiety, this can be for PTSD, because these things don't creep up overnight, right? You all are in the field a very long time. These don't just happen over a period of a week. These happen over a lifetime. And some people just get used to these symptoms and don't even recognize them as red flags, where some of these things to coworkers are like, no, that's something different than Natasha normally is. Hyperarousal. So think about, I go to drop something and it falls on the floor and the person across the room jumps up into the air. This is the person who has that startle response that you would not expect. Again, very edgy, very nervous, easily scared. And these are things that I do share are different for a person. They're out of that person's norm. So maybe they were very normally calm and, pretty put together and pretty relaxed. And now they are jumping at every little thing. A call comes in, an alarm goes off, and they are in the air. Avoidance. And this can be in many different ways. This can be avoidance of people, of places, or of things. It could be avoidance of coworkers. It could be avoidance of family. That's also a big symptom of depression for a lot of people. But avoidance of areas where they took a call and it was a hard one. I've worked with many first responders who, again, that one call that they still struggle with, that one incident, that one person, that one child, they do not go down that street anymore. I do not want to see it. I do not want to see that house. I do not want to relive that. And that is what the third point talks about, almost reliving what happened. I've worked with people and it had happened many, many years ago where they experienced something they were still struggling with. And when they describe it to you, it is like they are still there. It is like it is still that crisp fall day in December, because they can describe it with such detail and accuracy because they really haven't left the scene. Mentally and emotionally, they are still there. The flashbacks can be visual, and anything can trigger a flashback. I worked with a young first responder, and he had not been doing the job for very long, but loved it. But he had responded to the passing of an infant, and the smell of baby powder was a very big trigger for him. And he and his wife were expecting a child, and he said, I do not know how I'm going to do this with my kid, knowing every time I smell this, I want to start bursting into tears, knowing that I get angry, knowing that I want to snap at my wife. What are we going to do? How am I going to get through this? And so a lot of our work together was identifying those triggers and working to manage those emotions so that they could get through it and not over it, as a lot of people say. Like we mentioned, you're already on a sleep deficit, and then we throw nightmares into the mix. And now we have, if the little sleep that you did have was restful, now we take that away from you. Nightmares are very common. The first 3 of those bullet points are actually the first 3 criteria we look for in an individual who is struggling with post-traumatic stress disorder. And so they easily fit into what some people experience all of the time. Changes in work relationships, very common. Again, oh, Ralph. Let me see if I can do that. Lyra, anybody, if anyone can let me know what Ralph ended up saying, feel free. I don't want to mess up anything here in the presentation.
I was just typing in the chat. I was just saying another thing administration never really understood. I'm just kind of generalizing when I say administration, even though I have specific examples of my own, but was they never understood how we could show up to work tired. They always, their response was always, when we would bring these things up, like basically the employees were like begging for proper, healthier utilization of downtime.
Yeah.
And it was always, how can you show up to work tired when you were off all night the night before? Didn't you sleep all night? Why aren't you rested? It was always a lot of like finger pointing, like, well, what are you doing? Why aren't you rested? They never understood how poor of a sleep pattern everyone in this job has and why they have it.
Absolutely. And and thank you for sharing that, Ralph. And just the misunderstanding, or how very tone deaf to not understand that you would need to come down from a shift mentally and emotionally. And then by that time, I mean, however much time you have left to sleep, then try to get any quality of sleep. Yeah, that's incredible. Like you said, the misunderstanding. Thank you.
I mean, I would, oh, you're welcome. Thank you. I would bet pretty much everyone in this group, even on their day off, is probably not getting more than 4 uninterrupted hours of sleep at a time.
Wow.
Just from them, them waking themselves up.
Yes.
Unless you're drinking and then you're able to put yourself out for a little bit of time. I think we could all relate to that maybe, but that's just, that was my experience and still is, where, yeah, you're not sleeping well at work, but then you go home, you're not sleeping well, and you're up every 2 or 3 or 4 hours. So you're not really getting that long REM cycle. So that just
exactly
kind of leads more and more, and the circle just keeps going and revolving.
You're absolutely right. And to your point, we talk about, alcohol helping a little bit of that. But what we forget is, to your point of REM sleep, when we drink, there's that initial depressant of like kind of lulling us. But then alcohol does not allow us to get into the REM sleep. That's why we kind of hover in that sleep wake. So the sleep we get is relatively poor quality because we can't get that deep sleep. So even though we've kind of told ourselves over all the years, have a drink to help sleep, it'll oftentimes do the opposite for us. And Dr. Kafar, I think you had your hand up. I apologize.
Nope, accidentally hit it, Natasha. I'm sorry.
It's okay. I know you could come up with something if you wanted to add it. So anyone else that I missed? Ralph, anything else?
Yeah, I wasn't talking about myself with alcohol. I was actually talking about Joe Mistovich.
Just talking about a friend, right? Thank you so much. And again, looking at those changes in people over time, like you said, you all are on the schedule of an infant as far as sleep. And so being up every few hours, again, The brain is not able to recharge. It's not able to reprocess. The programming isn't able to get done when it needs to get done. And like you said, then the lack of understanding of why you just can't get this good sleep. Well, it's easy. You're not primed for good sleep. You don't have the conditions for good sleep. And so you will see all of these things start to add on to a person. Sleep greatly impacts memory. That's why when we look at individuals who have struggled with their sleep for many, many years, sometimes decades, there is a lot of memory impairment, inability to recall short-term memory as well as long-term memory. So you'll notice that people are not able to remember things, whether it's on calls or on documentation. The fuse is very short. Like I mentioned, that individual that I worked with, that is also very common with anxiety as well as depression and PTSD, a very short fuse, and that increased substance use, right? Of course, not for you, Ralph. I know you said that. But looking at how many more times are we having a drink? How many more times are we leaning on something that maybe isn't helpful to us? The way a body is responding, we always kind of say in our field, the body holds the score of everything that we have ever been through, whether you remember it or not, your body will remember it. And so sometimes that will come out in the physical shaking, the changes in a person's appearance, looking more tired than normal. And then, like we said, a person can't keep those lines separated. So the work will become inconsistent. The pace will become not reliable like it used to be. And you'll begin to see all of these things that will just snowball and snowball for a person over a period of time. Ways to help, talk. Please talk. It doesn't have to be to me. It doesn't have to be to a person like me, to a professional. Talk to one another because you understand each other the best. You know what you're going through. Check in on one another after a very tough call. If you don't get the support from administration, be the support you want from them to one another. If a person seems off to you, if you all operate probably a lot on gut instincts. I'm a gutty gal. I believe in gut instincts. And so if you feel like something is off, if something isn't right, please don't question that. Act on it. You can always be wrong. They can always tell you to kick salt, but try it. Remind one another of resources that you do know that you have, right? If you have an employee assistance program, if you don't, that is okay. If you have a support system, if your department knows of a counselor, psychiatrist, therapist, whoever, that they do trust, who does understand what you are going against every single day, please utilize them. I always say, if you do not know where to turn, please just call. Honestly, I'm on our Mahoning and Trumbull County team. If you have questions about where to access resources, I am also always available. Ralph, I've been off for what did it say, Ralph?
That was just me talking to Ralph, telling him that I've been off 24s for almost 3 years now, and I still don't sleep.
Yeah. Oh my gosh, yes.
Honestly, I'm on an insomnia bender right now on day 4. Get about an hour, maybe 2 hours a night.
Oh my gosh.
And
thank you, Matt. Oh my
just wait for it to stop.
Yeah. And that's it, is even having that understanding, like when you go and talk to someone, you all have that understanding of one another. We as providers have to understand that, because if I were to meet with you, or someone was to meet with you who doesn't understand that, they would go, probably have the same comment as administration. We'll just go home and sleep. Try this, try that. But that was your lifestyle for how many years? So to just break that, it's difficult. It's more difficult than we could imagine. And I'm sure you want it broken. It's just what's been ingrained for so long. Like you just kind of did for him, Matt, normalizing not being okay, normalizing, yes, you're going to struggle with this. Yes, this is going to be difficult. Not to have that suck it up old school mentality that maybe we are surrounded by some people who still retain. It sounds so silly, but these are the basics, right? These are meeting the basics. So drink water, sleep when able. 2 minutes are better than no minutes. I always say that forward is forward. Eat food that fuels you versus fighting you. So when we are looking for comfort food, we're going to crave something very salty, very sweet. It's going to be very specific. That's how you know something is a stress craving versus a real craving. When your stomach growls, it doesn't say the only thing I can eat right now is Wendy's French fries. It will just say I'm hungry. But when you crave the very specific, it is very much an emotional craving. Moving your body outside of work, right? You can put in here whatever works for you, but try not for it to be something that's overwhelming. So I don't try to tell people like to go to the gym, even though the gym is listed in here. If you already go continue. But it could be something as walking to get your mail versus driving up and getting it. If you're walking the dog, 1 extra lap. It doesn't have to be huge. It's the very small things that move a person forward, help get those stress hormones out of you. Because one reason you're not able to sleep when you get home and sometimes have that hard time coming down is because that adrenaline is still pumping. You need something to get that adrenaline out of you. And physical activity, as much as we hate to hear it, is one of the biggest things to do it. Especially if you have a busy brain, you sometimes need a busy body to go along with it. And I included some things in here that were a little bit more high energy, because what brought a lot of people into this field is the need for that adrenaline rush that you always get every single day. And so doing yoga may not help that. Doing boxing, doing cardio, doing running, doing lifting, those things may speak to that more and get that out for you. Limiting caffeine and alcohol, again, not eliminating it, just pulling back on it. So I love coffee. Coffee, I like to say, loves me back. But sometimes instead of having the 5 cups of coffee a day, it's the 4.5. It's the 4. We're not saying go from 5 to 0. I would never deprive you of that. But we're saying instead of having the 6 beers, have the 5. Limit time working alone and max of 12-hour shifts. I know that that is not always doable. And so that's why I put it in here kind of with a little bit of hesitation. Try not to work alone. I know you don't, but try to have as much companionship when you're working as possible. And if for no other reason, to have a person there who understands what you're going through right along with you. Kind of what Ralph was saying, speaking to the downtime, taking breaks or time off when you are able and when it is needed, so that you don't get to that point of burnout, of compassion fatigue, of feeling crispy before you've been burnt out. And I am a big person on boundaries. I am a big person on that no is a 1-word, 2-letter sentence. Saying no when you are able. I know that you are not always able to do that, but maybe it means saying no to something in your personal life when you know that you need to take a break from what's been going on at work. Maybe it is saying no to a person in your family who wants to talk about something they saw that you responded to on the news. Those can be the no's we're talking about. Keeping those boundaries up so it doesn't always feel like you are at work 24/7, 7 days a week. And some resources that are available to first responders, EMS, EMT, the Code Green campaign, if anyone is familiar with this, is revolved around helping provide that mental and emotional support to first responders, to normalizing that, to bringing education in. The Firefighter Behavioral Health Alliance is also one of those. Code Green campaign will also come in, I believe, and do free education on mental health. So that might be a place to, again, if you don't get the administrative resources and the support, that might be something that you look into with the person who is struggling or for yourself. The National Association of Emergency Medical Technicians is another one. They offer wonderful resources and support. Critical incident stress debriefings, the Mahoning and Trumbull County team, employee assistance programs, but I do know that some of that service does come with a stigma, so I am well aware of that. So I kind of caution when I recommend those things. But something that does help get rid of that stigma is just people participating in the program or just talking to an EAP and understanding what we do and what we don't do. That also helps break down that barrier. And one big thing that they mentioned was to encourage a buddy system. So again, keeping an eye on one another, checking in on each other. Again, the person next to you may be fine, but it does not hurt to ask. and to double check on that. You know each other probably better than administration would, so knowing when something seems off with someone and checking in on them. So does anyone have any questions or any final comments? I do just want to say, before I run out of time, I know Dr. Cafaro is our comic relief and he is chomping at the bit and he will have you laughing this evening after I brought the mood down probably a little. But I do just want to say thank you all very much for the work that you do, for how you risk your lives every single day, and for keeping our community safe. You do a job I could never do, so thank you. Does anyone have any questions or anything final before I hand it over to my dear friend? Well, I thank you all very much for your time this evening. And again, please be safe out there and have a lovely evening. I know you will enjoy your next hour. So thank you all very much. Have a good night.
Before Dr. Cafaro starts, I want to thank you. That was great. Thanks for hitting on a lot of those points that really mean a lot to us. And it's nice to know that there's people out there that give a crap. So up next is Dr. Michael Cafaro, chiropractor, team physician with Wethersfield local school district teams, and probably a lot of other stuff. He's a chiropractor and a friend of Larry's, and looking forward to this talk.
All right. Well, thank you, everyone. And it is a pleasure to be here tonight. I will share my screen as well. I just wanted to also thank Natasha as well. Eric, I saw a hand go up for a second. Wanted to thank Natasha as well. I've had the pleasure of working with her for quite a few years now. She is awesome, does a great job. I always tease if we do anything together. I always say she might be the cuter one, but I try to be the cooler one. But she is awesome. Sadly, talking about hard reality and depressive things. So hopefully, yes, tonight I will hopefully pump you all up a little bit. I am also going to see if I can share the screen here. See if I can get this entire screen. And just bear with me as well. And let's see, is my presentation up by chance?
It is.
It is? Okay, perfect. So I will actually start this then. Well, again, thank you all so much for having me. This hopefully will be fun and exciting, a little bit energetic as I try to be. Larry, I thank you and I thank all of you for the opportunity tonight. And I just want to start off by saying, I call the presentation Treating the High School Athlete, a Whole Team Approach. And we're definitely going to talk about that. This is based on clinical experience. So it's going to kind of be fun between all of us and hopefully some interaction as well. I appreciated the interaction earlier. So what I'm going to do is just talk about what I have been doing for the past 18 years and how I've been working with you all and how I have nothing but love and respect for each and every one of you. Some of you I actually might know if I would look through the list, or if when I mention teams I've worked with, you'll probably know that a little bit. So we'll try to keep it fun and interactive, but I am going to talk about the whole team approach. I'm going to start off with a little bit about myself. I am a doctor of chiropractic since 2004, so for about 18 years. Currently, I am the director of occupational health and chiropractic for Meridian Healthcare. Prior to that, I had my own practice, Cafaro Chiropractic Clinic in Mineral Ridge for about 15 years. I've been the team doctor for Mineral Ridge since 2005. I know I'm the designated school physician for Wethersfield schools is how it's termed, but basically been their team doctor. And I'm also the vice president of the Ohio State Chiropractic Association. And the reason I'm mentioning that is it's important because of politics and state laws. I was going to get into that a little bit later, but I'll get into it now. Just for certain rules and laws the state actually has. Currently, we have to have an ambulance at every home football game, but that is it. Now, they do have to have a critical response team, an emergency action plan, all has to be in place. But it's one of those things to where we'll definitely get into it a lot later, that some schools sadly just do not have a whole lot of help when we would need it. A couple other things I don't have on the slide. I've worked with high school, I've worked with college, and I've also worked with pro. So again, this is not research based, it's going to be more experience based, and hopefully we have fun along the way and can be a little interactive, and I just want you to walk away hopefully learning something. One thing I do want to ask, I might want to see if I can exit this for a second. One thing I'm noticing, my slide is taking up the whole thing. I really can't see your questions. Are you guys experiencing that too?
That's a thing typically when you're in presenter mode that you can't see anything. So that's what Matt and I do. We try to catch all the questions in the hands, and we'll let you know if we
Perfect. So I know I was able to see it with Natasha. So as long as you guys are doing your thing and can field questions for me, perfect. So I will get back onto this. So what I'm going to talk about is what is the job of the team doctor. And believe it or not, my job is not what you really would think it would be. This list here basically is it, and I'm going to elaborate. The main job is to assess injuries on the field to determine the level of care necessary, return the athlete to play when it's clinically stable and safe to do so, but remove the athlete from competition when applicable, which sadly happens more so than we would like to see, and determine when the athlete needs transported, assist EMS with transport, and stay out of your way. I will definitely be elaborating on that later on as well. And then communicate with parents, coaches, the ER, and then follow up with the injured athlete post-game night. This could be getting them to orthopedics, neurology, myself as a chiropractor, PT, primary care physician, dermatologist, dentists, podiatrist, you name it, we can send it there. I always sum this up when I'm training young trainers or young team doctors that are coming on with us. Our job basically is, are they hurt enough to where they need to be sidelined? Can they go back into the game? Or does this go to the ER tonight? Or can it go tomorrow? Do they need transported? And it basically is as simple as that. Everyone thinks, well, you're treating them and you're getting them back in. No, it's more triage just to see what we need to do with them. The number one goal is health and safety of the athlete. Get them back when it's safe to do so, and make sure we're not going to compromise anything by sending them back. So it's just health and safety, number one. Moving on to the next slide, which actually is one of my favorites. So it's when do we use EMS? This is obviously a very brief list, but obvious fractures and dislocations, head and neck injuries, which is going to be a big one, along with concussion and back injury, lacerations requiring sutures, a chest or lung injury. You're thinking, does that actually happen? Especially in football, if you take a shot to the chest and you break a rib, you sadly can puncture a lung. Rare occurrence, but it can definitely happen. So those happen as well. And then obviously any other medical emergency that we need to utilize you all for and your expertise. So one thing I really kind of wanted to talk about tonight is what I'm doing when I'm running out onto the field, what I'm assessing and what you all would be helping with. So the big thing is just determining muscle issues versus joint and ortho problems, which is one of the main things that I am doing when I'm going out there. I just kind of want to give a rundown. Again, not research-based. This is how I handle it, and I've been doing for 18 years, and it works out rather well. The three things I've come up with regarding assessments is observation, questioning, and evaluation. You've probably heard and been taught these in trainings. But how I do it is observation of the incident itself, and then observation of the athlete as you're approaching and running out onto the field or court or whatever it might be. The biggest take-home point is the team doctor must be paying attention. Must be paying attention. It's easy to get caught up in, talking on the sidelines or looking at your phone. You just can't do that. You have to watch and just be very attentive to see what's happening, because a lot of times you can figure out the injury before you're out there, you kind of know what happened as you've seen it. But when you get out there, you just want to know, how did the injury occur? How is the athlete positioned? Are they conscious when you go out there? And it leads to the second point of questioning, just asking the athlete what happened, where it hurts, etc. And then you get into your evaluation. I always like to observe myself, ask, and then get into it. I mean, you can tell when you're running out, they're holding their knee. Yeah, it's a knee injury, but just ask them anyway. You'd be surprised at the things that they will do, especially when they're in some shock, and the excitement of things initially happens. But you get into your physical evaluation next. And of course, your basic life support, first aid, CPR all apply. We all hope we never have to do these things, but sometimes it happens. On a little side note, and that's why I put this here, and you're going to hear me say it a few times tonight because it's one of my big drive home points. The team doctor should definitely coordinate with the other team's medical staff and EMS prior to the game. If you can do it by the phone, by reaching out to athletic directors from the other school, or just getting there a little bit early and trying to work with the other team, meeting the other team, trying to introduce yourself. Like I said, for football, an ambulance has to be there. So for the home team, so just introducing yourself to EMS and trying to do that. And then the reason I say that is, especially when I had my own practice, I'd be rushing from my last patient. I'd be heading to the game. I'd be getting there right at the beginning. Didn't have time to do that. So what I wanted to throw out to you all is, don't be afraid. If you're working a game, go up to the coaches on both teams, ask them if they have a trainer, ask them if they have a team doctor. Do they have anybody there? Don't be afraid to introduce yourself. I'll throw it out there. I'm a little bit more entertaining and sometimes a little bit more vulgar than Natasha. You will run into some idiots occasionally. Just, there's not too many out there these days, but occasionally you will have some that might give you a hard time. But for the most part, we are all appreciative of you being there. And especially when I get into this a little bit more, you'll see why I mean that from the bottom of my heart. But don't be afraid to get out there and introduce yourselves and just set up a strategic plan of what's going to happen. God forbid something should happen to where we are all needed out there. And it does sadly happen. And I don't have to tell you all that, that. So just introduce yourself, kind of come up with a system of getting out there to get things addressed. And we'll get into some ideas with that later on. A couple of them are comical. But again, don't be afraid. It's just a nice way to build that rapport and work together. My famous line is, it's the best seat in the house being on those sidelines. Hopefully you get to watch the game. Hopefully your team wins, and hopefully nobody gets hurt. That's what we all hope for. And that does happen, but not as much as we would like to. But getting on to determining muscle and joint issues is one of the big things that we're going to be battling. So just kind of wanted to go over just some very, very brief clinical pearls that you all most likely are going to know, but just gives a nice little refresher. When we're talking about muscular and soft tissue injuries, these are going to be more achy and burning, sometimes even shooting pain if there is nerve involvement, which often can happen. But these are going to be very sprain, strain-like presentations, usually along the muscle band. You're going to see them in ankles, shoulders, thighs, legs, wrists, pretty much any soft tissue, obviously. And they can be painful. And we'll talk about that a little bit later on too, as far as pain levels and pain tolerance that we'll see. But contrasting that to a joint and ortho problem, a lot of those are going to be, of course, pain in the bone specifically. You're going to see pinpoint pain, especially with fractures. What I mean by that, you'll run out there and the athlete will say, "Doc, it hurts right here." And they will point specifically to an area with their finger even and say, "It hurts right here." So and of course, it's going to be along the bone line, and you can kind of get some clinical pearls that way. Dislocations, sadly, are very common here. Most of these are going to be very painful and more painful than soft tissue. Not always, but they can be. And common in ankles, shoulders, knees, hands, back, neck, head. Again, pretty much anywhere. So there's kind of just some brief overviews of determining the soft tissue versus hard tissue when we're heading out there. What I want to do, and I know in talking to Larry, you guys have all had your training on concussion, head injuries, neck injuries, boarding, not boarding anymore, obviously, all the things that are being done. But I just want to talk about a couple conditions that we see commonly from my perspective that you will be helping with, that we see. Obviously, the first one, the big one, are the concussion and head injuries. So these are the most scary. Sadly, we'll have at least a couple a year. But when you're running out there, obviously the first thing we're doing is checking for consciousness, assessing neck injuries, and looking for obvious signs of intracranial bleeding. Then you're moving into your neurologic workup, orientation to person, place, time, checking balance and strength, observing your eye motions and saccades, and you're doing that off the field, on the sidelines, just depending on how stable they are to transport. One question I always like to talk about that we get asked a lot is when we're out there looking at athletes and assessing them, part of the neurologic exam is asking questions. What's your name? What day of the week is it? Where are we at? What year is it? Who's the president? You're trained to ask all these questions, and I always say ask the hard and the obvious questions. And we're always taught in training, well, don't ask them a question they know the answer to, because you want to check cognitive function. And I always say, yes, ask those hard ones, but ask some easy ones too. I will often ask an athlete, what's your number? And when they're concussed, I'm not talking obviously severe concussion, I'm talking about that mild concussion when we're still assessing and not quite sure. When they know, I'm number 77, doc. But sometimes they don't, and they're going to look down at their jersey and say, I'm number 77. Or ask them what the score of the game is. They say, you're not supposed to ask them that. They all know the score of the game. Yeah, maybe. But if they have a concussion, they don't really necessarily know. So they're going to look up at the scoreboard and they're saying, doc, we're winning 6-0. And I like to ask those easy questions that they say don't ask, because I like to see what their level of cognitive thinking is. Can they rationalize? I can't really remember my number. Let me look at my jersey. I don't know the score. Let me look at the scoreboard. It actually means a lot to let me know that they still have some good cognitive function. Doesn't mean I'm sending them back to the next play, but it does mean that it's hopefully not as bad as we were thinking at first. And obviously on all these, the team doctor is going to be deciding if transport is necessary based on severity. Obviously, we can all tell those stories of you go out on the field, the athlete's unconscious, we have to transport, all the scary things. And sadly, I've seen that over my 18 years more than I would like to. And that's the biggest and most scary. And I'd say probably have at least a couple a year. But this is obviously the big one. Another one that we run into that's going to be very common as well is shoulder. This is when we all love this. We talk about the energy and excitement, as Natasha was saying. We like that adrenaline. This one, you're going to see a lot of the gross stuff. You're going to see obvious clavicle fractures and displacements, glenohumeral dislocations, AC joint separations. You definitely see these are the most common ortho problems. But then sometimes too, it's just more of sprain strain issues, neuropraxia, impingement, any type of injury that flares, and you'll see that. So you might, after you determine it's not a severe orthopedic issue, you're going to assess for movement and range of motion and evaluate that shoulder. And again, that team doctor is going to make that decision. The big ones here, you're going to see some type of impingement. You'll see your fractures and dislocations. And again, some of these are the nasty ones when you're walking out onto the field that you tell when they went down, and you can tell by the way they're laying. Again, the scary ones. That's kind of why I wanted to touch on these. Another one is knee. This one too, you're going to have observe for obvious fractures, dislocations. Leg fractures are going to be common here. A little clinical pro I say with this one though, when you know it's a knee, give the athlete a few minutes to calm down. Knee injuries are a little strange sometimes when they happen. The less severe injuries will sometimes ease after the initial shock wears off, but those severe injuries are going to remain. And once they calm down after a few minutes, then sometimes you can assess them a little bit just to see. And that's kind of what I said we would touch on. Just be cognizant of individual pain levels. It can be a challenge. One person's 10 can be another one's 1, and you all know that. I tell the story every year that we had an athlete who was from South Range or Springfield High School, and every other year you're going to play at your field or at their field, basically. So, but when this kid was a sophomore, he came to our field and was playing in Ridge, fell, took a big hit, dislocated his knee. So 2 years later, he's back, and the same thing happens, the same knee. And that kid's pain tolerance was just absolutely phenomenal. I could not believe it. We had EMS and paramedics are out there, and they were actually put him on an IV on the field to get him transported. And I couldn't believe how calm this kid was with these injuries, sadly, both times. But you'll see it, which is why we're there. On a side note, I was going to get into it a little bit later, but at Mineral Ridge Schools, we are blessed. A lot of you probably remember Randy Pugh. He was our EMS chief for Lane, very good friend of mine. I was blessed when I first started. We had Lane EMS there. We still do. We had Dr. Catterlin as our team doctor at the time before he stepped away. But it was EMS with Lane. They're still there. We have police, we have fire, we have EMS, we have paramedics. I'm there. We have our trainer now. We have a physical therapist who's there. We have a tent. We have locker rooms. I mean, we have it all. I do not worry when I'm working a home game. I have so much help and a great system that we run through every year. And it's phenomenal. And I'm blessed to have that. So after Randy had passed, I had asked Tom Lambert if we can keep that tradition going. And he said, sure, absolutely. And I show up to the first game of the season, and there's Tom on the sidelines. I was teasing him and said, didn't have to be the chief working the games, but we are fortunate. We have so much help there. I know a lot of schools do. A good friend of mine is a team doctor with Cantfield. Another one's a team doctor with Austintown. And just getting that good crew is that whole team approach. Like I said, at our games, we can handle both sides of that field. We're going to talk about a little bit later when we talk about some barriers and challenges where that becomes a little bit of an issue. But regarding pain levels, you will see this vary in knee injuries. Any injury really can be, but knees specifically, just because it's so shocking, you don't exactly know what's happening. A shoulder dislocation can do the same thing, sadly. But you want to evaluate range of motion, pain levels, look to see if it's muscle and joints, muscle or joint, and see what you need to do. And of course, the team doctor will set that transport up with you all to get sent to the ER and taken care of. Another one I want to talk about is ankle injuries. And this is kind of the same type of thing. Obvious fractures and dislocations can be there. This is where I was talking about pinpoint fracture pain can be very common here. They will point to that lateral or medial malleolus and they'll say, doc, it hurts right here. And they will point to that. Where this gets confusing, it's also a common area for bone bruises, which can sometimes be almost as painful as a fracture. You're going to have severe sprains and strains here, which are also common and painful, high ankle sprains. And the issue with ankles, that's why I wanted to mention these conditions. They're possible in pretty much any sport the athlete's upright and running, which is pretty much all of them. It's not just a contact sport of, football or hockey or even soccer. You're going to have these in anything, cross country, track, basketball, any sport. You're going to sadly see these. These are one of the more common ones. And the big thing is just differentiating that muscle versus bone and joint and seeing if this thing is fractured, does it need to get transported, splinted and protected. And again, that team doctor is going to decide when that transport is necessary. Any questions so far on anything? All right. So what I want to do next.
I don't see any in the chat yet.
Okay, perfect. That's fine. What I want to do next is talk about my most important slide and my most fun slide. I think this is where we'll hopefully kick it in gear and I'll get you guys laughing. I want you to hopefully learn something or at least laugh and have a good time. The barriers to care are huge and we want to make sure we overcome those. The biggest one you'll see is in a smaller school or community, you might be the only show in town. That's why I want to say thank you to all of you because I've had the pleasure of doing this for 18 years and I'm actually thankful for that rule. I always tease poor Sebring, nice little community, great school. I knew the former coach there, good community to work with. When I first started as a team doctor, that we didn't have all the rules of having an ambulance there or EMS, paramedics, nothing to where it was basically they had whoever they could have as a trainer, which at the time, Sebring didn't hardly even have enough for a poor football team, let alone to have a trainer there. So there were times I would go down and work those games. When I first started off, Doc Catterlin, when he was with us, he would just work the home games. I would work the away games. I would head down to Sebring and I would be the team doctor for Mineral Ridge, but I would also be the team doctor for Sebring. They just didn't have anybody. and I'd have to work both sides of the field. And it was tough. It was a challenge. It was the biggest challenge we would have. Now having a trainer, we can kind of split those duties. She can work one team and I can help out the other. I mean, obviously we're both going to be with Mineral Ridge, but we could help out the other team as necessary. But what's phenomenal now, since all that rule's kind of been into place, now that there's an ambulance there, I usually try to get there and coordinate with that ambulance. And sadly, that EMS team will be working quite a bit to help us out because they're going to be on the field a little bit, helping out both teams. When you get into those small communities, that's kind of my drive home point is if you are tasked to work the game, you might be all that there is for a team doctor, for a trainer, for anything, and you're going to have to take care of both sides of that field, both those teams. That's why I want to try to give as many little clinical pearls as I could to walk you through it, because you get into those communities, they don't have the facilities, which is the second barrier. They don't have the help. They don't have the supplies. Like I said, in Ridge, we have everything. But when you get into smaller schools and communities, lack of facility help, it basically is going to be just you. Another barrier is parents, and I'll be respectful with this one. We'll have some fun with the ones after this. Most parents, they just care about their kid. They want their kid healthy and well. They don't want their kid getting hurt. So they're going to be respectful and they're not going to give you a hard time. Sadly, though, it can become a barrier because some kids feel that their kid is Tom Brady or LeBron James, and they're not, but they think that they are. And it really will push you to make sure you take control of that situation. And when that kid isn't supposed to be out on that field, it just stand your ground, because they will really sometimes push, we need my kid back. My kid's got to play. And I've always told the coaches that my job is to make sure the kid is healthy and safe and playing when they need to be and out when they should be. And that is it. But as far as playtime, and my parents know, they never come to me and say, well, talk to the coach to get my kid more playing time. Nope, I don't have those discussions. That's between the coach and the kid. And if the parents want to get involved in that part, that's fine. But on the field, you might get some push from parents. Again, most of the time not. They just want their kid to be okay. We had an instance of this last year. A kid really took a tough shot to the head. Borderline concussion. I hate using that term, bell rung. I never use it anymore. It is sadly a concussion, just more of a mild one, not your moderates and severes, as we can grade them, but it's something, it's still a concussion, and that kid's got to be out. And, so we had the parent wanted to push a little bit. At the end of the half, we had to pull him in, and at halftime, the dad's talking to us saying, I think he's okay to play. Myself and the trainer said, no, really shouldn't be. He said, well, I'm going to let him play if he wants to play. And they can sadly override our rule if we make that decision and we just document that. This way we're kind of covering ourselves, saying, there's playing against our clinical advice. The cool thing is he came back probably about 5 minutes later, right before the half was to start again, and said, you're right, I don't think that my kid should play. And was apologetic, turned around, and fortunately, glad that we didn't. The kid had a concussion, was able to come back and play the following week, and did great and had a great season, was one of the better players, especially for the size of the kid, and did fantastic. But the parents can come around, but sadly there can be some pressure. A lot of times you'll get pressure from the coach too. Doc, this is my starter. This is my A1 kid. This is who I need. But most of the time you're not seeing that anymore. Now that Lindsay's Law is out with heart issues, with the concussion laws, coaches just aren't going to chance it with kids. It's not like the old days of throw some dirt on it and out you go, you'll be fine. That kind of mentality is gone, thankfully. Every now and again you'll see it, but not much. Most of the time the coaches are just trying to coach the kids up. They want you to do your job as the healthcare provider there, and they're going to let you do your thing. One we're all teased, no offense to myself and Larry, but doctors can actually be a barrier too. I said I wouldn't say it. My wife said, no, don't say it. I'm going to say it. Sometimes doctors can be assholes. Hell, I think anybody can be an asshole at the time. So hopefully I don't offend anybody with that, but it's true. Sometimes doctors can be a barrier. You will have a team doctor, and it's fortunately he's retired. I won't mention his name or what school he was with, but every time we would run out to help, would shoo us off. I don't need it. I don't need EMS. I've got this. I've got this. I've got this. And where I want to pick on the doctors a little bit. If you're an ER doctor, yep, you can do it. If you are an orthopedic surgeon, pretty much can do it. Or if you're a doctor that was a paramedic before you became a doctor, or EMT yourself before you became a doctor, okay, I'll give you those. But as far as me, I learn emergency medical procedures in school. I have to keep up with them throughout the years. But my famous line is, I don't do this every day. You do. I used to tease Randy all the time because he would tease myself and Doc Catterley and say, why am I doing all the work out here? And I finally looked at him and I said, because you do it better. He said, we guys are the doctors. I said, sure. But we haven't splinted, and of course we don't board anymore. I said, we haven't splinted, boarded, done these emergency procedures since school. And some of these doctors that are going to say, I've got it. No, they don't. You do. My famous line to Randy was, you did this 6 or 8 times before you came to the game today. I haven't done this in years since I was in school. And that's why I say back up and stay out of your way. You know how to splint. You know how to do it properly. You know how to transport. You know how to get these kids meds. You know how to do everything to keep them stable. And that's when my job takes over to do the other things where I'm talking to the coaches, I'm talking to the parents, and just getting out of your way to do what you do. Doctors will sometimes push, and that could be a barrier. You will go out there, you know you need to be out there, especially if you see someone doing it wrong, which sadly happens. Again, not so much anymore. We're pretty fortunate. We've got a lot of good help in the area, I feel anyway, and I've seen over the years change to where some of that old school mentality is gone too. But doctors, I mean, there are some that are doing this, but most of these are, family doctors, maybe internal medicine doctors. You'll have some sports meds, some orthopedic, like I said, that can handle it. But for the most part, they need to step back and let you do your thing. And that's where communication comes in, which is one of the other barriers. You kind of have to set something up beforehand, and we'll get into that too in one of the next slides, about having a signal as far as us calling you all out to when you know you need to get out there. And that's changed over the years too, and I've got a couple cool and funny ones with that. But communication, you just take down that barrier by introducing yourselves and working with the sidelines and just getting something figured out so you can break down that barrier. Last barrier I have on here is the big game. It matters because we need this to get into the playoffs. We have to win this one. This is a tournament game. Basketball tournaments are starting up here soon. Well, they already have. This is a tournament game. We need to win this one to move on for the tournament. And sadly, for the coaches, for the school, and for the kids, that game might have more weight. But from a healthcare perspective, that game is no different than any other game. A scrimmage is just as important as a state championship when it comes to our jobs. A kid goes down with a knee injury, head injury, back injury. It doesn't matter what the game is. So we really have to kind of isolate ourselves. And when I first started doing this, that was a barrier for me. Because I realized, I got to get this kid out. This is our star kid. We win this, we go to the playoffs. And you can't have any type of judgment affect your clinical judgment. You can't think, I need to get this kid out. No, you need to make sure that kid is safe and healthy, which never changes, whether it's the first game of the season, the last game of the season, playoff scrimmage, it just doesn't matter. It's the health, safety, and well-being of that athlete that's the number one priority. And that never, ever changes, regardless of the type of game or any of the barriers that we battle. So that's kind of where we're at here. Let's see. Any questions so far before I move on with that? All right. So I want to talk. What's that?
There's a question from Dan Hughes.
Okay, go ahead, Dan.
Hi, Doc. All I'm going to say is if a doctor interferes with our protocol, we will have him ride in, and if he denies, we're just going to resume our protocol and not go any further with it.
Okay. So, well, good for you. You're saying you'd have the doctor ride along with you in the ambulance?
That is correct. And
Okay.
if he decides not to, we will not follow his direction.
Okay, good for you. Yeah, and that's the stuff where I get frustrated, Dan. It's just we and again, even if it is an ER doctor, they've got a team helping them too. That's kind of my whole big point. It is bigger than all of us. It takes all of us. It's bigger than one individual. It takes a whole team to play that game on the field, and it takes a whole team to take care of that team. I'm excited to see things that are happening across a lot of the schools these days. But I love that. Yeah, just call that doctor out. You know what, doc, you want to run this? Come with us in the ambulance, because that doctor cannot leave the field and leave those kids. And I'm glad to hear that. That's awesome. That's an awesome way to handle it. There's times that usually I will work the game. I have gone to the ambulance afterwards, or gone to the hospital afterwards, or followed the ambulance to go check on the kid. I've done that a couple times when I've transported some of those severe ones. Usually, for the most part, when I get in these next couple slides, we'll talk about how we handle that these days. But yeah, thanks for sharing that. I'm glad to see that, because you all do this better than any doctor. And I know some doctors might argue with me on that, but they're wrong and you're right. They're not doing this all day. You are trained, they're trained to do their job and you're trained to do yours. And bottom line is we need to step back and let you do yours. So thank you. That's great. Anybody else have anything? Perfect. So I'm going to get into some of the take home points, especially, and why I put these on here is this is for a lot of you, if you are in that small community and you are the only thing there, the muscle versus joint thing, just realize those soft tissue injuries can be broad and less severe. They still could be painful though. You're going to have them in those joints, the ankles, or in the muscles, ankles, shoulders, legs. Cramping is another common one that you're going to hear about and you're going to see. And you might have to run onto the field quite a bit for this one, especially in the fall as the weather cools down. It's hot in the summer when they're practicing doing 2 days. Still hot in August when they're starting. September it starts to cool down. When you get to that end of September month, beginning and end of September, pretty much all through September, you're going to start to see these kids going down with cramping. And in Middle Ridge, I laugh at this. We have trained on this for 18 years. I can't change their mind. They've got a bottle of French's mustard on the sideline and they all just share it and suck it down and squeeze this mustard in when they get these cramps. I just laugh. Now, the new thing, the COVID friendly thing is, well, we have to have individualized mustard packets. So they open up these and throw those things down. And I just laugh like crazy. At that point, I'm not saying it doesn't help, but it's too late. They needed to hydrate all week long. They needed to hydrate the past few days beforehand. And if they have a common cramping issue, they need to supplement as well with hydration. But it's that day of the game is not the time to start. And when they get that cramp at halftime, right after halftime, when it cools down, it's in the second half. Oh, I'll just take my mustard. Way too late. You'll get them stabilized, you'll stretch it out, and you're gonna be back out there in 5 minutes anyway. But it's just something that's commonly happens. It's comical. Coaches have gotten better. I'm lucky I have a good rapport with my coaches. Kids that commonly cramp, will get them on some magnesium, making sure they have a hydration regimen, half their body weight in ounces every day, hydrating all week, hydrating pretty much all season. But all week and especially in the few days before, just really hitting hydration hard. So, but cramping is a common one, and it's scary because you're running out there and you think, oh, is this a knee? Is it an ankle? What is it? Because they're really grabbing their leg, and it's that famous line, oh, it's just a cramp. Well, they could be very painful. They can get spastic and tight, and having to work those out. Hopefully, there's a trainer there that can help handle those. The tough part, why I have it in a take-home point, is when you're dealing with all these cramps. We're on the sideline stretching out athlete after athlete after athlete, and there's times we've got 3 and 4 of them out there. We try to train our kids to do some stretching for us so we can continue to watch the field. This goes back to that first initial slide. You're over there stretching and you missed a critical injury that we have to call EMS for and get transported. So again, that's where it goes back to taking all of us, not interfering with your protocols, us doing what it is that we do, and working together. So you'll definitely see that one with cramping. Joint and bone pain obviously is going to be more severe. The clinical pearl there is just watching for those pinpoint fractures when they point to that specific spot on the bone. Dislocations are common. The big one though, the drive home point on that is the head and neck injuries. Those are obviously the most severe and need all the available help. And that is when I step back and let you all do your best work to stabilize. And that's when I'm doing my other things, which takes me to the other side of the slide of when to transport. That doctor runs out there, we do our initial evaluation. This could be, I shouldn't even say just team doctor, trainer, whoever it might be doing but I just wanted to come at this from a team doctor perspective since that's my role. We do our initial evaluation, determine, muscle versus joint. Then the decision of transport is made on clinical necessity. That's why I said we'll assist and help you in any way, but we really just need to stay out of your way. What I do anyway, when I have to call you all out, that's when I am doing, at that point, I am talking with the family. I'm talking to the coaches and reaching out to the emergency departments. We used to have to in the past. What the great thing that has changed way back when I first started doing this in 2005, it was with Ridge, I'd have to, I had the charge nurse phone number in my phone, and I would be calling ahead to the ER to let them know what was coming. The beautiful part is now working with you all, you guys are taking care of that. You're calling it in, letting them know what's coming. Or if I ask you to help me out with that, most of the time, every time I say, hey, can you let the hospital know what's gone? And usually the response is the same. It's already done, doc. We've done it. I said, perfect. So this way, you guys are taking care of that transport, even talking with the hospital. They know what's coming in. You can get the kids stabilized. Yes, I work in an addiction facility now, but you guys have the good meds to keep them calm, keep them stable, comfortable, get them transported safely. And I can talk with the family at that point and the coaches, especially things like dislocation. One thing I didn't touch on, I forgot to mention, as a chiropractor, I cannot put a dislocation back. It is not in my scope. Even though we can manipulate things, we don't do relocation of a dislocation. And you don't really see it much on the field. You used to every now and again. And maybe if an orthopedic is on the field, they might. But for the most part, just archaic and barbaric. Get the kids stabilized, splinted, get the good meds in them to keep them calm, get them to the ER, do it under images, get the right thing, do it the right way. We had that typical, Springfield athlete I was telling you about. Once he was given some IV meds and sedated a little bit, that thing kind of self-relocated back in, which was a good thing. So as opposed to trying to be barbaric and slam this thing back in, you don't have to prove anything to anybody. As a team doctor, let you all do it and transport it properly. That's actually why we have a tent in Ridge. Not because we're putting those things back in, we're not, but just because it could be gross. It's another little thing that we can kind of talk about. When you go out there and there's an obvious dislocation, usually, you never want to crowd the kid. You don't want to scare the kid. But when I'm seeing an obvious dislocation, I will crowd that kid on purpose. I'll get some coaches, maybe even another player out there, because I know I'm going to need you anyway, and let you do your work. But I try to keep that kid's eyes and mind off of what is really going on, because sometimes they look down and they see that ankle spun the opposite way, or that knee bulging out, or whatever protrusion it might be with a tibia or fibula. They will freak out. So you want to kind of keep them calm. I always try to distract them, let you do your thing, and I've just got the kid focused on me, looking at me, so they're not looking at that. But again, that's part of letting you do your thing, and part of my thing is just keeping that kid calm and talking to the coaches at that point. And I love what you said, Dan. Yeah, EMS might have to step in and really kind of just put everybody in place sometime. And hopefully you don't have to do that very often. Hopefully the reality is, again, my biggest drive home point, and I'll say it a million times, you do it better than anybody, so let you do it. And the other point is, you get into that smaller community, it might just be you there. You might be doing everything, and you're the only thing. Bottom line, like I said, is the athlete's safety and health is the most important. We want them to see next Friday, but I also want them to see Fridays 20 years from now without any difficulties. And that is the big thing. So one last thing I wanted to kind of go over is how we all work together, and this is where I can kind of tell a couple funny stories as well, and then we'll open up to some questions and hopefully some other good stories shared. But we all work together to treat the athlete. Like I said, we're running out there first. EMS is called out with a signal. I waited to tell this till the end. The old universal symbol used to be, we run out into the middle of the field and, we just make an X with our two hands and arms together. Well, the tough thing is we have to make sure that you're close enough to see that, understand that. You always have to coordinate that at the beginning of the game, like I had said, with communication. But things have definitely changed. 2022, there's a lot of things that we can do different. One thing that I like to do prior to the game, if we don't do any type of call signal, just having a call or text to be made to EMS. I mean, when I'm working at home, I've got Tom Lambert there. I just give him a call. I've got Jeff Tucker with me. I give him a call. We've got I've got everybody on the sideline with me that I can reach out to, but call or text. But one thing that I'll do with the away teams, again, I always pick on poor Sebring, but I use them. I will go over early before, and just because I know I will probably need them a little bit since I'm the only one there typically, I will get a phone number for one of them as long as they don't mind, and I'll share it with them. I'll say, listen, I'm going to send you a text if I need you, and if I don't have time to call, and that'd be the kind of the universal code, and that's the way we handle it. So there's a couple ones that we use. We've gone as simply as just for ambulance. Tough part about that is they're waiting and thinking, they're trying to say something else to me. 911 was one that we used to use, but you have to be careful with that one. You have to make sure that you are texting the person appropriately, as opposed to just hitting 911 on your phone, because then obviously you're calling another ambulance. So the one that I usually like to just text is simply EMT. I get their number and I just text EMT or EMS, and then they know that that's needed to come on out. And that's kind of how I usually do the call, is when I know I need it, I kind of just program that number, get it ready, and I just send a text that says EMS, and out they come. My buddy, who's another team doctor, I thought this was funny. He's like, I use NAR. I'm like, NAR? So what the hell does NAR mean? I use EMS, Emergency Medical Service. He's like, I use NAR, need a ride. And I started laughing. I thought, well, all right, hey, you can use that. It's whatever you come up with beforehand. But again, it's that communication at first, just to have something. That's the way that we can do it. I always in Ridge have whoever it is with EMS with me, because you guys have the radios, so you can make that easy. How I handle basketball is a little different. Basketball, we don't have to have an ambulance there. But what is there is security. So I usually, when I work a basketball game, I am not on the sidelines with the team. I usually will let the trainer do that, and I stand along the wall with the police officer. Because if I know that I need EMS, I always have the police come out with me, and I just give them the head nod, and they call it in on their radio, and it's there faster than I'm going to do messing around. Not to say messing around with 911, but just going through the process is just so much easier. So I will work with the police to call you all out as well. Track meets are probably one of the toughest ones, believe it or not, to work, because usually there's multiple teams there. We all have trainers, but there usually is not much staff on site. Sometimes there is, sometimes there isn't. And for that, we just typically have to call 911. A big meet, a lot of times there will be an ambulance there. Lane is very good to us. Usually when we're working our Joe Lane Invitational, Lane is there. So if we have to do that. So those just a couple barriers, but anything you can do to come up with a signal code, that's how we handle it. And then that transport's needed. Like I said, the doctor steps back, because we are thankful that you are there, because we don't perform these every day in the office, which is where I get really frustrated and mad at any doctor or trainer that says, oh, I've got this. I learned it. You did learn it, but you don't do it every day. You're training every day. You're being a doctor every day. You are not being an EMT and paramedic every day like you all are. So that's why I utilize your services first and your expertise first. So with that, I wanted to say thank you, because what you do makes what I do easy. I am blessed to know so many of you and to work with so many of you over the years. It has just been a lot of fun. I'm gonna get out of here. I wanted to open this up to any questions at all. Anything, so I can even, I'll stop sharing this and just come back. Does anybody have any questions or anything? I know I went a little quicker there, Larry, so I can take up any extra time. We can talk about any type of other topics, clinical issues, anything you want, anything to come.
One of the things I just want to say is that Stewart in Trumbull Regional Medical Center, right when the football season comes, we actually go out to the people in our protocol and we do sports injury training. And with that, we're reviewing the types of orthopedic injuries, the concussion, and we're also taught, how to get the sporting equipment off of the patients. We're also talking about if we had to move a patient off of that football field, yes, that would be the time to use the backboard. But then as soon as we get to the sideline, we would take them off of that backboard. On top of that, we like in the fire departments that I've worked for, we've invited the athletic trainer or the team physician to the fire department during that training in order to get them familiar with not only our protocols, but what we're capable of doing. And so last year, the athletic trainer, who is a physical therapist, came down to the fire department and he's like, I had no idea what you guys did. I had no idea is that you guys don't backboard. When I learned it, everybody got a backboard. So it's just, communication with the school or with that team physician of what's going to happen. So you don't have an incident on the field where you're going to do things my way and EMS and this team physician kind of get into it. And then the other thing that you and I have done is, we've gone up to each other and did what I termed as an EMS timeout. And everybody if you've ever had surgery or you've gone to any procedure, the nurse says, okay, we're going to have a timeout. We're going to verify that, hey, this is Larry Monero. And Larry, what are you having done today? Oh, I'm having surgery on my left knee. Okay. So not only does that decrease risks in the surgery setting, but we can apply it to EMS. So you walk up to that physician or that trainer, or even that coach, and I just coined an EMS timeout. And when you start branding that, they'll look forward to that and say, hey, we're going to do a timeout. I'm Larry with the fire department. I have 2 ALS paramedic ambulances. I have 2 paramedics, 2 EMTs, and this is what we're capable of doing. And before the season starts, whether it's that text message or whether it's a physical hand signal, like crossing your wrist up in the air, that way EMS knows to come out into the field. And that's worked really well. And I know that previously when I was at Lane, we had Youngstown State University and their athletic trainers and even their athletic trainer program students. That's one of the things we had to educate them on was backboarding because they were still, it's a relatively new concept within the 6 or 7 years or so. But educating everybody is one of the biggest things, and just have cool minds, and everything will work out.
Absolutely. And one thing I can add to that too, and I appreciate that input as well. That's why I said, that communication, really just getting there and introducing yourself and getting that. One thing we do in Mineral Ridge is every year we have to have at least, we try to take 20 minutes out of a practice of every sport to actually even train our kids a little bit in case something were to happen with one of the coaches. You always say, stay off the phone as you're practicing, but you have to have a phone out there in case you have to call 911 and just say, hey kids, you've got to have the school address memorized, or the gate where we're going to have to send an ambulance, or the door where we're going to have to send an ambulance to come in and just get those kids trained. Another one I probably should mention too, I know we're talking about the athlete, but anything can happen with coaches. But does anybody know the other common group that you will unexpectedly have to treat?
Cheerleader.
Spectators.
You will have a cheerleader every now and again, absolutely. But referees, referees are the other thing that will sadly happen. This was quite a few years ago before Ridge had turf. Our grounds crew did a phenomenal job of maintaining the field. But when we would get to those October games, that thing was just mud and big holes. And we had a ref slip, have his ankle go into the hole and just blow out a knee. And it was terrible. So it was just one thing you don't necessarily expect. You're always looking at the athletes, but sadly you will have, cheerleaders are athletes as well. So you're going to have to look at all sports that are happening at that time. But the athlete on the field or the court, cheerleaders, refs, and coaches. Occasionally, sometimes you'll get a call into the stand. That one's a little bit tough because I need to be on the field. So when they say, hey, someone's got something going on in the stands, that is usually the time that I'm calling EMS. because I don't know what that is. I don't know who that is. I know a lot of these kids, and I take care of a lot of these kids, a lot of their families, so I know what's going on. But when it's some stranger in the stands, not that I don't want to help them, of course I do as a doctor, but I don't know what that is. It could be a heart issue, it could be anything, to where you're better to handle that than I am. So I usually will reach out for that. And we'll have that every now and again too. That one's not as common, but I'd say once every couple of years you'll get a call into the stands to take care of something that might happen there. But refs, that can be common. Refs will get hit and plowed over. Refs will fall and hurt themselves. A colleague of mine had a ref sadly have a heart attack on the field, was out there, and EMS saved him, which is a cool thing. He's over in Pennsylvania, and had that happen, and he said that was kind of the scariest thing for him. So you'll see that. Bottom line is, just as you're encountering every day when you go to work, all these things can happen on the field too. So you never know what's going to happen. But I appreciate it. Does anybody else have anything?
Doc, I had somebody text me a question because they're having difficulty with Teams. So
Sure.
Their question is, let me see here. How can EMS deal with back and neck soreness, and what can they do to maintain the spine? Because all the equipment is obviously heavy, and we usually throw a 40-pound bag on one shoulder while carrying another bag on our left hand, versus the right hand. And you and I talk about this all the time, but share with those people who haven't necessarily been exposed to chiropractic care or physical therapy or muscles and physiology.
That is a huge one. I have a lot of EMS as patients of mine, EMTs and paramedics, because of the gear. The thing I always will preach, if you can, it's very hard to do, but if you can and are able, when you're carrying the gear, if there is any way to have it in a backpack that can go across both shoulders, I know it's easier said than done. Or if you have a little bit of ambidextrous to where you can throw it, one shoulder on one call and another shoulder on another call, just balancing that weight. A backpack bilaterally is the best, or just carrying that bag side to side versus that same routine overall. Again, easier said than done though, because of what you have to carry and what you have to have. So those are things you can do on the job just for prevention and stability. One other thing that can happen too, obviously, is when you have these things happen, you're gonna have back and neck pain. The longer you do it, the busier you are, the more you're throwing around patients and all the gear, is you might have musculoskeletal issues yourself that need addressed, and chiropractic care can address that to align that spine, get some strength and stability, some mobility into that spine, get some inflammation out. Physical therapy, another great way to have strength and stability as well to maintain that spine. Massage therapy, even acupuncture, all just natural ways to basically do two things: get inflammation out and blood flowing into that spine, but to get mobility and function so you're stable overall to handle your job. But chiropractic to align things, physical therapy to strengthen, massage to relax it, even acupuncture, just good natural ways to go, and good therapies and treatments and modalities to utilize, which is, it's a common problem. We'll see a lot of police, a lot of fire, and again, EMTs, just for the gear and what you're doing every day, all day. With you guys, it's a little bit different, kind of like Natasha talked about, sleep deprivation, and for EMS and fire, it's just tougher. I mean, it's a brutal, grueling schedule that you guys have to go through, and especially these past couple of years with the pandemic, just the increased number of calls and what you've had to see. So those are definitely great treatment options. That's again, working as a chiropractor, but in an addiction facility as well. We see, not that I'm anti-medicine by any means, but we try to have a drug-free approach to work with it naturally, and then in conjunction with safe meds that can be taken that don't have addictive properties. But yes, chiropractic is a huge way just to help with that and keep that spine mobile and functional. That's a great question.
Awesome. Well, if there's no more questions, we'll let Doc go, or he can stay on the line and listen to the next lecture. What we'll do is we'll take a couple minute break. We'll have everybody put their hands up, And that's how we take attendance here, Doc. So make sure they
Okay.
don't fall asleep during the lecture. Put your hands up. We'll come back in 3 minutes, which will be 8:06-ish. And we'll get started on geriatric case presentations. And I'm hoping we'll get some participation from the crowd.
Awesome. I'll tell you what, I appreciate it. Thank you for having me. And if you all need anything else, feel free to reach out. And thanks for having me tonight. It was a pleasure.
All right, everybody, let's move forward with geriatrics, get you guys out of here on time. So the reason we added the geriatrics was to satisfy the state of Ohio requirement so that by the end of this, if you've done everything that you need to do up at the paramedic level and everything beneath, you'll have all the time that you need for trauma, geriatrics, pediatrics. So we want to make sure we give you guys that opportunity. So today we're going to talk about everything that's geriatric that has had an EMS implication. whether that's local or around the area. And we just kind of want to show you what people have done and want to see what you guys are going to do. So we're just going to review the differential diagnosis and treatment for the geriatric patient, and that's what we're going to do today. There's about 4 to 6 geriatric cases, and let's get started. Real quick, we just want to make sure that there are people from a couple different states over here, a couple different protocols. So what my recommendation isn't necessarily what your protocol is. So please follow your protocol and whatever the administrative policies are. And obviously do what's in the best interest of the patient. So the very first case is going to be an 85-year-old female complaining of abdominal pain. And this happens all the time. And here's your patient. We'll call her Janet. So Janet is complaining of abdominal pain. So right off the bat, what are some differential diagnoses that you think that the geriatric patient could be complaining of? What could be the reason for this?
Constipation. Go ahead and speak up, folks.
Constipation. Okay, constipation is one of those. Sorry about the pen. Constipation is a big thing. Okay, you can kind of see where she's kind of guarding herself a little bit. So let's just see constipation. So we're all very good at the alphabet soup and memorizing acronyms and whatnot. So when we look at the sample in the OPQRST, let's go forward. So she's holding her stomach, all right? That's the signs and symptoms. She has an allergy to penicillin. She's on Coumadin. She has a history of GERD and atrial fibrillation. The last oral intake was 1 hour, and the events leading up, she had dinner and had intermittent pain. The onset was at 7:06 p.m. It's intermittent. It's sharp. Nothing really makes it better. And she kind of says it's right across the epigastric region, maybe over to the right side a little bit, going up to the right shoulder. It's 8 out of 10. And it's been going on for about 4 hours. Does this help you guide with what you think might be going on with this patient?
Does she have her gallbladder removed?
So that is a very good thing. So as far as we know, she has all of her organs. So so cholecystitis might be one of the differential diagnoses. So let's keep that in mind. So now let's look at her vital signs. Vital signs: blood pressure is 140/78, heart rate a little tachy at 110, respirators are 22, GCS 15, SATs 94. You do a sugar and found it's 148. She's pink and dry, pupils equal reactive, and her end tidal is okay. So overall, her vital signs seem to be pretty good. So of course, with all abdominal pain, we're going to take a 12 lead. And this is what you see in the 12 lead for the advanced and the paramedics out there. Do you see anything that's abnormal or that is concerning with this 12 lead?
Narrow QRS.
Okay, narrow QRS, yeah, that's what we want. We usually say, what's the rhythm, what's the rates, is there 1P for every Q, and is there any abnormalities with conduction delay? So there's 1P wave for every QRS segment. That does not, the QRS is narrow. If we try to put this rate is right around what we said it was. So let's say we're going to start here. So 300, 150, 100. And what did we say she was? We said she was about 110. So that's fine. So we did the 12 lead. We look at her like, I really don't see anything wrong with that. Let's move forward. So you have the female complaining of abdominal pain. The 12 lead looks okay. The vitals seem to be okay. What would you do for this patient?
Treat for pain.
Okay. So what do you want to treat her for? I mean, what kind of pain medicine?
Fentanyl and Zofran.
Okay, fentanyl. Sure. How much fentanyl?
About how much does she weigh?
Oh, that's a good question. Good job. So let's say she weighs about 150 pounds. So just give me a dose. You have to give me the exact. So how much per kilo would you want to give her?
Probably
how many mics? 1 mic per kilo. Okay, so we're going to give her 1 mic per kilo. Okay, and you said Zofran. Yeah, okay. So why are we giving the Zofran?
Just prophylactically for any nausea.
100%. That's right. That's one of the common things that we don't do as EMS providers. If you're advanced EMT, go ahead and give the Zofran. That's going to be ODT. If you're the paramedic, you can make the decision whether or not you want to give ODT, or if you want to give IM or IV, go ahead and do that. So I agree with that. So we're going to go ahead and do Zofran, and we're going to do some fentanyl. Okay, very good. So the leading diagnosis that you have now, are we still going with gallbladder issues, or do you think there's something else going on based on what we found out?
Sounds like GERD.
Pancreatitis.
Okay, so your differential could be pancreatitis. What makes you think pancreatitis? I heard GERD.
Oh, simply if she is having a gallbladder attack, she could have dropped a stone down into a duct of her pancreas. Or if she's just having a gallbladder attack, simply the bile that's backing up from the gallbladder will simply just ooze into the pancreas and irritate it.
Yep, that's one of the physiology behind pancreatitis. Yeah, very good. GERD, I think somebody said GERD. Jen, was that your voice I heard?
No, that was mine.
Oh, okay. I can't see anybody. I just heard a voice. So what makes you say GERD? Just simply the fact that she has a history of it, or?
She has a history of it, and it started about an hour after she ate.
Okay, good.
Like
so
right
as the food gets into the stomach, it's starting to increase the acid, right? And go from there. Okay. So I agree with what there's a good differential. So we'll put gallbladder on here. And my pen's not working. There, gallbladder. Okay, so it's actually cholecystitis, right? So the gallbladder, whoever said gallbladder was actually correct. Cholecystitis is a medical term for an inflammation of the gallbladder. And with this, it's the #1 surgical emergency in the elderly. Cholecystitis increases the onset of it increases as you age. So for EMS, we did exactly what we need to do. We're going to treat their symptoms. When they get to the ER or into the hospital, they're going to do an ultrasound. The risk factors for gallbladder is the 4 Fs. So they're going to be female, 40 or older, fertile, which means that they're going to have multiple gestations, right? And we don't say fat, we say fluffy. So the 4 Fs, female, 40, fertile, fluffy. So if you have a female who's complaining of abdominal pain, what we want to do is we want to kind of put our hand over top the right upper quadrant, push in, and have them take a deep breath. Right when they take that deep breath, it's going to push on that gallbladder wall, and that they're going to have some difficult. That pain is going to increase rather, and so that's that's called the Murphy sign. And so when you do that, you're almost kind of geared towards the gallbladder issue. Here's a picture of a gallbladder on ultrasound. Not that we're going to do this in the field, but I just wanted to show you that the gallbladder duct is going to be here. All right, this area here is bile, and this is going to be the gallstone right there. This is the gallstone that I'm currently covering it. Now, the gallstone, you can see, is kind of covering up the drainage for that duct. And what's in here is sludge. This stuff in here is sludge. That's pretty much bile that hasn't been able to escape through that duct. And what happens is it becomes stagnant and it starts to thicken up. When it thickens up, it's going to clog that tube, just like anything else. So then when the gallbladder goes to contract, it can't really push everything out. That stone is going to be free floating, and that stone can actually go into the duct and be a local lithiasis. So gallbladder stone that's stuck in a duct. So this is kind of cool because you can kind of now put everything together about the gallbladder. But just remember, elderly female who might be a little on the heavier side, doesn't always have to be, have multiple kids. You do the Murphy sign, which you're going to curl up underneath the costal region and have them push in and have them take a deep breath. It's going to hurt. You can pretty much say that's going to be gallbladder, cholecystitis, and treat them for the pain, treat them for the nausea, treat them for the pain, and give them some fluids because they're probably going to need that. These are 2 different gallbladders. The gallbladder on the left here, these yellow stones right here, those are cholesterol stones. If they were to do some sort of imaging like X-ray or something like that, it wouldn't show up. All right. But the black stones that are here, those are biopigment stones, and those are you can actually see those on imaging. So this is a real gallbladder, and so you can see that gallbladder has over time built up and not able to perform its function. When the gallbladder is not able to actually perform a function, it will actually start to kind of atrophy, and it'll start to kind of ruin itself. It almost, not to the point that the pancreas auto digests, but what's going to happen is it's going to lose its elasticity and ability to squeeze. Then that necrotic area that's not getting good blood flow can actually turn, and it can be what's called a porcelain gallbladder, and then sometimes it can just kind of explode. And when the gallbladder explodes, that's a big major way for the abdominal cavity to have massive infection, and it makes things worse. So if you're having gallbladder issues, at least go and get it checked out. And they say you should probably get it out. We want to get out the gallbladder before it looks like this. The gallbladder on the right-hand side has a bunch of cholesterol stones, and they can have hundreds of stones. And this one looks like it has hundreds of stones. So two different pathologies, both cholelithiasis, which is gallstones. Both gallbladders had to come out because it wasn't functioning. And then the other speaker is right. The bile can actually back up, and one of these stones could actually go into the bile duct and common bile duct and perforate through, and then it can lead into some other things. So good, that was gallbladder. So this patient, what happened is they stopped her Coumadin. Usually Coumadin is about 5 days to a week. They're going to stop that. They're going to take her to surgery, and then the gallbladder comes out, right? And she has a unremarkable recovery. So now Janet calls you back 4 days after her cholecystectomy. She calls you back. So that would have been 5 days stopping the Coumadin. She went to surgery. Now it's 4 days after. So say 9 days or so that she calls you back. All right. She's still complaining of abdominal pain, and it's the same female. We look at this stuff. Now we take her vital signs. The vital signs, her blood pressure is a little bit lower now. It's 100/50. The heart rate is even tackier at 120. Respiratory rate has increased. GCS is still okay. Pulse ox is 90. BGL is 140 again. Skin is now pale. Pupil dick reactive light, and the end title is 31. You start to ask her some questions. She tells you, I have my gallbladder out. And then all of a sudden, this happened. She also tells you, though, she's short of breath. And you ask her what's going on. Like, I just kind of been taking it easy since my gallbladder surgery. I don't know why my area hurts. And she tells you, she points back to the right upper quadrant, right where it was. And so now she has the abdominal pain and she's short of breath. Now, what are your differentials?
She could have threw a clot.
Could have threw a clot. What makes you say that?
With her SpO2 and her being off her Coumadin.
That's a very good observation. Yeah. So we stopped the Coumadin 5 days before the surgery. So we have the surgery. Now it's 4 days after that. And so you say, hey, hon, you shouldn't say hon, but you say, Eric Ginson, that I know he likes to use the terms, but so you might say, hey, Janet, that's her name. Janet, did you resume your Coumadin, or what happened? And she's like, no, I didn't. I've been on the couch. I haven't moved. I haven't taken my Coumadin. So the differential would be definitely through a clot. Absolutely. Any other differentials?
If she has been inactive, maybe some pneumonia.
Yep, that's it. So she was just in a hospital, right? So maybe she has some community-acquired or hospital-acquired pneumonia. Very good. So those are great things. So now we're going to dig a little bit deeper. What's your treatment for this going to be?
Definitely the 12 lead.
Okay. You're going to give her oxygen at the SAT of 90?
Sure. Probably throw on an end title just for everything's.
Yeah. Oxygen end title, sure. Let's say, how many liters do you want to give her?
I'd probably start like 2 or 3, brother.
Very good. 2 liters per minute. Less is more in this case. Very good. Would you do anything for that pain?
Sure.
Okay.
You probably do the same thing, the fentanyl, Zofran.
1 mic. Okay. 1 mic per kilo, fentanyl, and some Zofran prophylactically. All right, good. This is your 12 lead. do we think about this 12 lead? Is it okay?
PE.
Pulmonary embolism. Why do you say PE?
You have a large S wave in lead 1. You have a Q wave in lead 3 and an inverted T.
And that comes right from the cardiology queen herself. So I think that's Sheila Doan. So that's exactly it. So you have your S1, which is going to be right there. Q3, this is right there. And then T3, which is the inverted T wave. Yep. So again, this came from the geriatric lecture that we did the other day. And this is the 12 lead for PE. So she's short of breath. She hasn't been moving, like Eric said. She was off her Coumadin for what, 9 days now. So yeah, you look at this 12 lead and you're like, okay, I'm taking a PE. Very good catch. So the diagnosis, pulmonary embolism. And for reference, I put my previous slide on here from last week's lecture, so you guys can see that it does happen. And this is a case where you will have somebody who has some sort of surgery, and they'll be, they won't be moving, and they're going to just either forget or start to ease back into their Coumadin or their blood thinners, and they can have sudden onset of shortness of breath or pain. So the reason I put the abdominal pain in there was a little bit of a trick, but this was true. So because of the lung in the costal margin, because she was, elderly, really can't perceive pain that well, she was still complaining of pain in this region, but it wasn't abdominal pain per se. It was just overall pain, and struggling to breathe, and the intercostal muscles trying to work so much. So that was a very good diagnosis by by everybody actually. So pulmonary embolism. So remember, anybody who sudden shortness of breath with whatever else is going on, decreased mobility like this, like Janet had, we know we can kind of clue in that she stopped her Coumadin, and then we don't know anything else. The gallbladder is out. We know it's not that. So what are we going to go with? Pulmonary embolism. That's exactly right. Good job. All right. So we have a 64-year-old male with weakness. Happens all the time. Code 3, lights and sirens for weakness. Just before we get into some of the history, what are some of the reasons for weakness? I'll lead you off. I'm going to say diabetes. Anybody else? I know the answer is because I made this lecture.
All right, I'm going to start volunteering people.
I'm going to say dehydration. The list is running thin.
UTI.
UTI, very good. That's one of the #1 causes. Okay.
Bob Carter, do you have any differential diagnosis? I'm just picking people randomly.
All right, well, let's move on. All right, so you find out that the patient has an MI and has 2 stents. You find out that the patient's diabetic. They're in renal failure. They have hypertension. They have hyperlipidemia, right? They have the whole works. No allergies, and their meds. They're on Lantus, carvedilol, amlodipine, Remipro, and aspirin. So pretty significant cardiac history. You combine that with the renal failure. Lantus is controlled for diabetes. Carvedilol is like a rate. Amlodipine is a calcium channel blocker. So an aspirin. So we're going to look at the vital signs. The vitals, blood pressure is 110/78. The heart rate is 34. The respiratory rate is 18. GCS 15. SAT 92%. VGL is 148. Skin is pale and dry, and the end tidal is 35. So I think we're all going to focus on that heart rate of 34 and the SpO2 of 92. So now knowing this, where would you say most likely, what's one of your differentials? Where are you leaning towards?
Has he been taking his meds as prescribed?
That's good, right? Yes, I can tell you he is taking his meds as prescribed. So let's move forward. We decided to do it 12 lead because that's what's important, right? We do it 12 lead. This is what you see. Anybody besides Sheila can answer what this rhythm is.
Jeff Wagner.
Electrolyte imbalance.
Okay, that's differential electrolyte imbalance. What is this? What would we call this rhythm here?
It's the Brady rhythm with peak T waves.
Okay, so you mentioned the peak T waves, and here are the peak T waves. Very good, Roman. It is Brady. We know that's 34.
It's block.
What's that? Heart block. Okay. It's block. So, what would you? Is this sinus Brady, or is this a different term?
Looks junctional.
Junctional.
Very good. Yeah, so it's junctional, right? So we know it's junctional because there's no P wave anywhere above these things. So yeah, it's junctional. We know junctional is somewhere between the area of 20 and 40, right? Sorry, 40 and 60. 40 and 60. Okay. So maybe, yeah, so it's right around it's junctional, but I just made up 34. So now you have that. You have the bradycardia. You have the shortness of breath. We know he's in renal failure. He's got a junctional rhythm with peak T waves. Does that lead you towards anything specific?
Might be hyperkalemic.
All right, I heard dialysis. Somebody said dialysis. Go ahead with your theory on that.
Maybe you missed it.
Sure, we missed. Okay. What else?
Hyperkalemic.
Hyperkalemia.
Hyper K. Okay.
Acidotic.
How would he become hyperkalemic? Acidotic. We'll say metabolic.
Renal failure.
Yeah, right. It could be that. Sure, absolutely. It could just be the fact that his kidneys are not working well, right? So let's figure out what this is. Those are all very good answers. Differentials. This is actually called Brash syndrome. And Brash syndrome is something that actually came to light, and actually the disease pattern was actually solidified in 2016. And so Brash syndrome is going to be bradycardia, renal failure, AV node blockade, shock, and hyperkalemia. So what were we able to pick up on? We picked up on all of these. We picked up on bradycardia from the heart rate being low, renal failure because of the history, AV node blockade because we said it was junctional, shock, blood pressure wasn't really there, and then hyperkalemia because of the peak T waves, right? And somebody, I hear a little bit of background noise, all about you guys, participating, but when you're not speaking, could you just mute it, please? So Brash syndrome here, what happens is you have somebody whose kidneys are not working correctly. So what did we say from last Thursday? We said that with the elderly patients, right, they're almost chronically dehydrated, right? We lose most of our total body water. And then we also know that the kidneys will decrease in size and the kidneys are kind of taxed more, right? So with that, you have somebody who's going around who's in a chronic dehydrated state. And then you add either a rate control, either a beta blocker, maybe a calcium channel blocker, either for heart rate control or either for blood pressure control. What's going to happen is when the kidneys are not working correctly, or if they're in renal failure, that combination of that incident with the kidneys and the beta blocker or the calcium channel blocker is going to lead to hyperkalemia because the kidneys can't do their job. The bradycardia with the renal failure will lead to hyperkalemia. That hyperkalemia is further going to cause poor renal perfusion and going to worsen the outcome. And then what's going to happen is the kidneys are going to realize, hey, I have lower blood pressure, and the kidneys are going to try to activate the renin-angiotensin-aldosterone system that we talked about, and it's going to make everything worse. So you have chronic dehydration or renal failure you have some sort of rate control rate control or some sort of medication for blood pressure that can act on it. That's going to cause two things, hyperkalemia and bradycardia. You're going to increase your poor perfusion. It's going to come back to the kidneys. The kidneys are going to be taxed even more, and you're going to get the BRASH syndrome. Also, just if somebody's on an ACE inhibitor or an angiotensin receptor blocker, so either like lisinopril, anything with a pril, or losartan, anything with a sartan, those can cause either renal failure themselves, or it can cause hyperkalemia themselves. And that combination can lead independently from that drug. It can lead to hyperkalemia. The hyperkalemia causes the bradycardia. The bradycardia is going to cause poor renal perfusion. The kidneys aren't going to get perfused, so they're going to have renal failure, and they're going to go into this BRASH syndrome. So it's relatively new. I didn't learn about this when I was in paramedic school. So BRASH syndrome is something to pick up on. You guys picked up on it. Maybe you didn't know the term, but you picked up on all the signs and symptoms, which is very good. So when we look at this, we have to figure out, is it just a problem with the rate control? Is it just a problem with the beta blocker? Is it just a problem with the pure hyperkalemia because of the kidneys? But then when we start to get the combination of that, and then I'm going to throw one more circle into here, and it's going to be just old age, right? So we just now add that in there because the processes aren't working. Now you get that overlapping, and that's going to have BRASH syndrome. So with BRASH syndrome versus hyperkalemia, BRASH, you're going to have a smaller degree of hyperkalemia versus just hyperkalemia by itself. So as somebody said, I think it was Roman, but you're going to see the QRS and you're going to see the peaked T waves. That will lead you more towards BRASH syndrome. With hyperkalemia itself, you're going to see more signs of hyperkalemia. Those T waves are going to be super tall. That QRS is going to widen, and then you could have a sine wave, which is kind of like this, right? That could be what your EKG looks like, and that's going to be the hyperkalemia symptoms. So with BRASH, you're not going to see these accentuated T presentations or the EKG presentations. So that's one of the differentials there. BRASH syndrome versus AV blocker intoxication. All right. BRASH syndrome, we already know that the geriatric patient is usually chronically dehydrated. So when the summer months come, it's going to make it more likely, and they're going to be more susceptible to the BRASH syndrome. And obviously, you combine that with the renal failure or the poor urine output, that's going to make that differential more likely than the other. These patients usually will comply with their meds as normal. So they know in order to survive, they have to take their medications, and they will do so like clockwork. When you have an AV blocker intoxication, you probably will not have that hyperkalemia. You might just have the bradycardia. All right. So normally these patients aren't compliant, and so they miss a dose and they say, oh, let me take 2 to make up for the 1. They're just not that well educated in how the drug works. This slide here will show the gender and age on the left-hand side. It'll then go on to show the medications involved. It'll show the potassium, the creatinine level. It'll show their vital signs, and it'll show the treatment that they did in the ER. So what this is trying to show you is that elderly patients, all right, who are on some sort of beta blocker, heart medication, blood pressure medication, is affecting the potassium. The potassium for a normal adult should be somewhere between 3.5 and 5, right? That's 3.5 and 5. So once we get above 5 milliequivalents per liter, we actually start to have some of these effects. And if you look all the way down this column, what are we? We're above 5. We can diagnose kidney failure. No, we can't diagnose it in the field in EMS, but diagnosing kidney failure is based on your creatinine level. And for a female, it's 1.2. For a male, it's 1.4. So anything greater than 1.4 means that your kidneys are not working correctly. So let's look at this column here, and you can see almost everything is elevated. So based on those medications, looking at the age, now you know the potassium, now you know the creatinine. These patients fit BRASH syndrome based on the lab work. Then we look at the vital signs. which is going to be over here. Let's look at some vital signs. Heart rate of 38, heart rate of 28, heart rate of 33. You get the point. They're all bradycardic. Let's look at the blood pressure. 86 over 50, 120 over 59, 100 over 56, 60 over 30. Again, shock-like patients, all right? So what they have to do is, because the potassium is so high, intravenous calcium has to be given to protect the heart. We don't want the heart to stop. So calcium is going to block the potassium from having an effect on the heart. And then insulin, usually with some dextrose or some sugar, with some albuterol, is going to have the effect that it's going to drive the potassium back into the cell. And then we're going to give them some potassium diuretics to get rid of the spare potassium. So things that we would do EMS, but it's important to recognize the signs. And if you are picking up a nursing home patient or somebody who is in therapy or rehab, and you are able to say, hey, abnormal labs, well, maybe you might want to take a look at those abnormal labs before you just hand it off to the EMT. All right. So what are we going to do? We can give them fluid to manage the hypovolemia. They're going to get dialysis. Catecholamines. So we have epi push dose pressors, we have epi drips, whatever you have, to increase the heart rates and to keep the perfusion going. If we know the potassium, or we can kind of call and say, hey, look, I have a strong suspicion it's Brash syndrome because of this, then we can go ahead and give IV calcium pre-hospitally. The albuterols is when we really know what the potassium is, then they'll start to do the albuterol. Atropine is probably not going to help because we actually need some sort of drive to increase everything. Glucagon, if it's a beta blocker overdose, that's not going to be enough. 2 milligrams, 2 is not going to be enough to overcome the beta blockade. And what if it's not a beta blocker? What if it's a calcium channel blocker? Then glucagon won't work at all. Pacing will work to increase the heart rate, increase perfusion, but we need to fix it. So it's a metabolic problem. So we can continue to do what we need to do in order to maintain and preserve life until we get to the ER. So that was a challenging one. You guys did a really good job on that. But just be aware of Brash syndrome. Kind of take a peek at potassium and creatinine levels. If you do get abnormal lab patients, look at the vital signs and do that almost before you decide you're going to downgrade that trip from ALS to BLS. And same thing, maybe you decide that you're on an EMT car and you decide, I know it's abnormal labs, but this just isn't making sense. Call for the ALS and you have full justification as to why you did it. All right. So now, 65-year-old female motor vehicle collision. So car versus guardrail, you have intrusion 20 inches forwardly. The seatbelt was worn, the airbags were deployed. You approached the scene. It took you 7 minutes to get there, and the patient was lethargic. And they have blood coming down their face. All right. So you try to talk to the patient, and you can't get anything out of the patient. She doesn't answer questions, and she just kind of mumbles. All right. The skin is pale. It's cool to touch. It's winter outside, so she's wearing, winter clothing, layers, sweaters, puffy coat, gloves, hat. You're 17 minutes away from a level 3 trauma center, and if you request a helicopter, they have a 20-minute flight time after their pre-check, which can take up to 8 to 10 minutes. So we know this patient. We kind of know this patient's unstable. So is there anybody that would call the helicopter versus going to the trauma center? Let's say that you're easily able to extricate the patient. Can I hear arguments for both or either one, level 3 trauma center versus hospital versus helicopter?
I would call a helicopter.
Okay. Tell me why. Just
so right now she looks like she's, I think we can at least say that she has a questionable loss of consciousness going on as far as her neuro. Not sure about any other injuries at this point. So it's going to take time for me to get her, if you will, if I need to, I should say, once I do some more exam, an established airway. So a DSI, or a delayed sequence intubation, it's going to take a little bit of time. And therefore, by the time I do all that, figure out what's going on with her. Obviously, I get to have IVs, I can get my medicines, and I can get her to a level 1 where the fixers are. The helicopter would be there roughly by the time I'm done getting her all packaged.
Okay. All right. That's a good argument for the helicopter. Anybody say level 3? If you're able to extricate her in, let's say, 5 minutes.
I know you and I talked about this, Larry, and 100% level 3. Something's better than none. I know level 3 doesn't have every service that this patient may require, but you're getting them to some type of definitive care versus sitting there waiting for a helicopter.
Yeah. So if this was my patient, now there are good arguments for both sides, right? If this was my patient, I'd have to consider how far away, and I didn't put that in there, but how far away is a level 1 trauma center, right? So, and I know the utilization of the helicopter, they have blood, they have surgical airways, they can do a lot of things too. Well, so can the level 3, right? The level 3 has docs, anesthesia. The trauma surgeon by the law in the state of Ohio has 30 minutes to get there. But they could do some sort of stabilization. So if you look at the clock, and if you can get this patient out in 5 minutes and it's 17 minutes away, now you're 22 minutes in, right? That's before the helicopter. Let's say you call a helicopter at the same time. You know, that pre-flight, if they're not in the air, that could take some time. Then you have to do the weather check. And then, you know, what if there's a delay? You know, maybe that helicopter's not at that base. But I gave you the ETA right now, but I just wanted you guys to think critically. Maybe the helicopter isn't always the best solution when you can, you know, definitively, if I jump on the highway or I take this road, I can be at a level 3 trauma center. Maybe, you know, I can be at a level 1 trauma center in you know, 25 minutes, 30 minutes, whatever. But, you know, in Ohio, obviously, go to the closest trauma center or the most appropriate trauma center. So I just kind of threw that in there to see what the arguments would be, because there are good arguments for both. But 22 minutes and they're seeing a doctor and they're getting blood, that's pretty good. Helicopter has all that stuff too. There's a lot of unknown variables with both, but you know, just keep that in the back of the mind when you're utilizing the helicopter or when you're deciding to transport. So this patient, you know, the previous person was already talking about what they needed to do. They talked about DSI, which would be like an airway. The patient is kind of semi-responsive. So what do you guys want to make sure you take care of? I'm going to give you one. It's A, airway.
Airway.
Yeah, very good. Good. So let me just kind of do this for the sake of time. So airway, breathing, circulation, right? So when we do this, the airway, she's making sounds. Breathing, she's making sounds again, but we now have to figure out, is it the rate okay? Is the effort okay? We notice that there's a little bit of increase in the rate, and we see that she has some normal effort. We're going to see that for circulation, she has bleeding from the face. Would that really be concerning?
I'd say unless it was obstructing her airway in some sort of way, then might be something you need to address secondary.
Sure. Yeah. So we all know that airway, right? Impeding the airway, and also if it's some sort of arterial bleed, right? The face is full of arteries. So if it's not pulsatile, it's not spurting across the car, maybe note it to move on. But if it is something that you need to take care of, you go ahead and take care of it. You also find out that the patient's pulses are rapid and thready. The D and the E. So we all know ABC. What does D and E stand for?
A disability.
Disability, yep. So with her, the disability, we don't know what's going on with her, but she has incomprehensible sounds. She localizes the pain, and then her eyes only open to pain. So if anybody had me for any of my classes, you know what the next question is going to be. What's your GCS? Anybody can answer this. And when you do this, I'm going to know the eyes, the verbal, the motor. I don't know what you're doing. You guys can take out your phone. You guys can take out your phone and look at the app to figure out what it is. Come on, guys, you know this. This is you're calling a trauma report. Everybody should know the GCS. I know it's getting late, but you know, this makes us for some good conversation.
I'd give her a 3.
Well, okay. So you're saying 111. I'm going to tell you, thank you for playing. Next contestant. So we think about this, right? The eyes, right? We're going to talk about the eyes. The eyes open the pain. We know that 4 is spontaneous, 3 is going to be verbal. We know that 2 is going to be pain, and 1 is going to be none. So the eyes are going to be 2, verbal. We know that 1 is none. We know that if we can't understand her, it's going to be 2. We know that if she's saying inappropriate words, that's 3. Confused is 4, and we know oriented is 5. So this is going to be 2, and motor is going to be 6 is obey, and 5 is going to be localize. So that's going to be 225. So this lady's GCS is 9. All right. So it's winter time, so that's the elements. You get her. If you're trying to get her out, you know, you're going to try to get her out as best as you can for whatever reason. In the back of the image, you cut off the clothes, and you find that she has bruising to the right chest and to the abdomen. The abdomen's firm, and there are no distal fractures, and the extremities are intact. All right. So you're obviously concerned about this patient, right? She's ultramental status, and she looks like she has some internal bleeding. So let me ask you this, regardless of what your protocol says or who you're under, what does the PHTLS or ITLS standard say? How should we treat this patient? And I ask this question because we follow AHA for cardiac, and PHTLS and ITLS are kind of like the guidelines for trauma. So if I figured if I ask this, we can have a more non-confrontational. Go ahead.
I forget, what was her blood pressure, her initial blood pressure?
I didn't give you one. I didn't give you one. That's okay. So, but you would want to see what the blood pressure is. Yes, go ahead.
Yeah, I certainly want to keep it between 80 and 90.
Okay. All right. So you're saying blood pressure between 80 to 90. Oops. Okay. Good. All right. How old did we say this patient was? This patient was 65 years old. Okay. So 65 years old. Maintain that blood pressure. All right. So if you're going to maintain that blood pressure, what kind of fluid are you going to give? Assuming you're a ground unit and you're just an ALS unit. All right. So we're going to give normal saline. We're going to start an IV. What size IV?
14.
Okay. 14, yeah. So a lot of the times 14 was our go-to for trauma treatment. So now the research is saying that, you know, the 18 would be acceptable because 18, you can go ahead and give blood through that. And the research found out that if you went anything larger than an 18, that you risk the chance of actually giving too much fluid. And then if you give too much fluid, you're going to tax the kidneys and cause the patient to go into renal failure. So although 14 was a previous standard and it's ingrained in most of our heads, 18 is now the acceptable one. But you're going to do a large bore at the very end of the day. You're going to do a large bore IV. The blood pressure, when we talk about it, we want to maintain cerebral perfusion pressure. So we want to kind of aim this blood pressure. You know, there are things as permissive hypotension, but for blood pressure, when you look at the NASEMSO guidelines and the guidelines, they're going to look for a systolic blood pressure of 110. All right. Is it achievable? Maybe. But as long as you're above 90, then you're doing something. The problem is we don't want to overshoot the 110. So try to aim for the 110 systolic blood pressure. So you're going to start an IV, let's just say 18 gauge. You're going to give them fluid to maintain a systolic blood pressure. And what about the bleeding and stuff? She has internal bleeding. What can we do with that?
TXA.
TXA. Yeah, very good. So with the direct bleeding or with the external bleeding, we're going to do direct pressure tourniquet, and if we need to, we can do some other devices. But with bleeding that is not controllable, right? TXA is the answer. So a lot of people would say get in the truck and go, which is true because they need a surgeon, they need a hospital, and there's nothing wrong with that. But TXA is the answer. That's 100% correct. For you who said TXA, what do you know about TXA and how it works?
Oh, basically, just like I said, it's a clotting mechanism. I mean, it's pretty basic on that. The only thing that you're worried about though is seeing how she might be a multi-system, which you're okay with this. If they were just simply a head injury from the accident, TXA would be definitely contraindicated.
Yeah, so there are a lot of studies that are now coming to light about head injuries, and so it used to be that TXA was an isolated head injury was a contraindication to TXA. The latest research on that is saying that they might have jumped the gun a little bit when they said the isolated head injury. I recognize what you're saying, and that's in a lot of people's protocols for that there. But looking at the research, the TXA is the thing to do for this multi-system. In the isolated head injury, we don't really know what's causing that. We assume it's some sort of bleed. So I would agree with you. Maybe you hold that a little bit. But the research is interesting if you get a chance to look it up. So we're going to do the TXA, right? So it's an analog of lysine. It inhibits plasminogen activation, and so essentially what it does is it prevents the breakdown of a clot. So it doesn't cause you to clot. Your body's doing that normally. It prevents the breakdown of the clot. Yesterday, or last week rather, we talked, I'm going to do very little integration with farm. We talked about the extrinsic and the intrinsic factors, right? We said the intrinsics were 11 or 12, 11, 9, 8, 3, 4, 7, and we said 10, 5, 2, 1. So these were your intrinsic, these were your extrinsic, and this was your common, right? So now what I want to do is I want to focus on the common pathway. So you have your intrinsic, you have your extrinsic, and they come together for this common thing here. All right. So it starts off with 10 on the previous slide. So factor 10 gets converted to 10A, right? A just means it's activated. Then what happens is this 10A is going to be used as an adjunct, and it's going to help clotting factor 2, which is prothrombin, convert to thrombin. All right. Thrombin is necessary for the pathway for the mesh, which is going to convert fibrinogen, which is clotting factor 1, to fibrin, which is essentially that mesh that we want, right? That's the mesh. So now what happens? The body gets to this point, and the body says, okay, I'm making all these clots. I'm using my clotting factors. That's not necessarily a good thing. Even though we have to do it, the body says, no, wait, I can't use all my clotting factors. I need to break up my clots. So as more clots are formed, eventually what happens is we degrade these clots naturally. And how we do that is the pathway plasminogen converts to plasmin, and then what happens? We break up the clot. So how does TXA work? TXA is going to block the conversion of plasminogen to plasmin and plasmin to the clots to break up that clot. That's how TXA works. Just to kind of refine your knowledge a little bit, it doesn't cause the body to clot. It doesn't do that. It prevents the body from breaking up its natural clots. So on the other side of things, it's contraindicated in somebody who has a pulmonary embolism, not because we make the pulmonary embolism worse, because what are we giving to break up that clot? We're giving TPA. So TPA does the opposite, and TPA will actually activate this pathway from plasminogen plasmin to degrade those clots, because it's what we want to do with a clot. All right. So I hear this all the time when I teach students that, they don't really quite understand the TXA, but I wanted to kind of show you this because now you can tie some things together. All right. So what can we do? Obviously, we want to prevent acidosis, hypothermia, hemodilution. So we're going to restrict the fluid, maintain that systolic blood pressure right around 90 to 110. We're going to prevent hypothermia by keeping them warm, and prevent acidosis because we don't want to tax the kidneys. And so we want to limit our fluid. All right. As the gentleman said, it's going to be for multi-system trauma, usually less than an hour. We're going to be there within an hour, more than one system. We're going to use it in hemorrhagic shock where they're losing blood, right? We're not going to do a distributive shock. We're not going to use it for hypovolemia. If they don't have an allergy, they'll know, hey, I was given this drug TXA. I'm allergic to it. I can't get it. That's fine. That's when we're not going to use it. But chances are they don't have it. But one of the old criteria was you have to be far enough from the hospital that it matters. And that's no longer true, especially in our protocol. We used to have it when this first came out in 2015, 15-minute transport time to the hospital. That's not true anymore. If you notice that the patient's a multi-system trauma, or you assume they could be a multi-system trauma, guy flies off of a motorcycle, does a Superman, and lands onto a pile of rocks, he might not be actively bleeding. You might not see any bruising right away. But what is it? He has a potential for multi-system trauma. The guidelines are saying go ahead and give it. And that's what we're advocating for here too. And I know we're getting close to 9 o'clock, but let's see what else we can talk about. All right. So let me talk quickly about this patient here. It's an 81-year-old chest pain patient brought to Trumbull. The chest pain, the male was pale, diaphoretic, Lorton-oriented, mid-sternal, non-radiating chest pain for 4 hours. Doesn't want to go to the hospital, but the wife calls, you're going to the hospital. So you know what he's doing? He's going. He's getting his ass to the hospital. So what happens is, obviously, we know this is a patient who has, the chest pain. And so with chest pain, we know that we can have any sort of lung pathology. We can have any sort of cardiac pathology. We're going to try to figure it out. And one of the things we can do is obviously obtain the history. The history is he had 3 MIs before. He has high cholesterol, hypertension, 3 bypasses. He has heart failure. He has an allergy to penicillin. He's on metoprolol, Lasix, which I put both there, nifedipine, and aspirin. So he's on some protective heart medications. He's on a diuretic for his, probably most likely for his hypertension, and he has an extensive cardiac workup. Blood pressure is 134/78. Heart rate is 122. His SAT is 93. His RESPR is 20. BGL is fine. Pupils are okay. Skin is pale and clammy. End tidal is 37. So take a look at those vitals. He's tacky. His SAT is 93. And his blood pressure is good. All right. So if there's an EMT out there who wants to talk, EMTs, would you want to treat this like an ACS? Would you do an EKG, transmit it to the hospital? All right. Well, the answer is going to be yes. So you would do this, and you decide to take the EKG and transmit it to the hospital. Now, for the paramedics, I really want you guys to answer this. I want you to key in on this because this is important. This is the EKG that was pre-hospital sent, pre-hospital transmitted to the hospital, and they also submitted with the report. This is the actual pre-hospital EKG. Tell me about this. Somebody talk to me about this EKG. Tell me what you see. This is why it's called education, right? Continuing education. If you don't know, it's okay. Let us help you so you can understand. You can be a better provider.
Okay, I see elevation in 2.
Elevation in 2?
AVF. 3 and AVF are kind of hard to distinguish there because of tracing.
Yeah, sure.
However, he looks like V1, on the septal leads. V1, V2. I mean, he's obviously elevated in 2, 3, and 4, 5. So basically, it looks like he's just he's inferior, maybe.
Okay.
A little bit of lost for words there for a minute. They'll come to me. Sorry.
That's okay. You said something about the septal leads and the V leads. Tell me about those. You just said you didn't say the elevation.
Yeah, I'm sorry. To me, it looks like he's he's septal and lateral because he's got elevation and was it 3, 2 and 3, and then of course 4 and 5. So he could be anterior with the anterior with the 2 and 3. And then of course the septal, that's obvious. I mean, with the lateral, I mean, he's got a little bit of lateral extension there with 5, it looks like.
Okay, so when you say 2, 3, you mean lead 2 and 3, not V2, V3, right?
Oh, I'm sorry. Well,
I just want to clarify what you're saying.
It looks like he's got elevation in 2. I couldn't really tell much in the 3 and ABF just because
the
tracing
some artifact there,
kind of,
right?
Yeah, but
okay.
but the V leads, I should say. V1, he looks a little bit of elevation, but I mean clearly V2, 3, 4, and 5. Looks like he's anterior septal, a little bit of lateral infarct with the V5 elevation.
Okay. All right. So let me just kind of clean this up a little bit. So if I'm going to say, let me see here. This would be my isoelectric line here, I think. And this would be my isoelectric line here. And this would be my isoelectric line. I'm trying to make lines for you to make it easier.
Yeah.
Here's my stuff here. Here's my isoelectric line here. Here's my isoelectric line here. All right. So what we do know for sure, right, is we do know that V5, V6 has some depression. That's pretty clear. We know that V4 has some depression, and that's pretty clear. We really don't know about these two, so let me just cross it off because there's some artifact. We see here that he's got that pitch. So when you look at the QRS, does this QRS look wide, or let's focus on lead 2. Does this QRS look wide, or does it look narrow? Or do you think that looks like that because of the elevation that you're seeing?
To me, it looks like just because of the elevation I'm seeing.
Okay. All right. So one of the things I want to focus you on is, we're all told, never to really obey the top of the 12 lead because, we don't want to kind of know what's going on until we make our own diagnosis. So that is true to a degree. We want to kind of come up with our own thing. One of the things that you can almost always trust is you can almost always trust the QRS here, the QRS interval. And the QRS interval is 0.13, and so we know that by definition that's greater than 0.12, right? So with that, we know that this person is going to have a little bit wider complex. So just by that QRS interval right there, we know that there's going to be some sort of bundle branch in there. So now, where it gets hard at is that a bundle branch delay, or is that going to be some sort of STEMI, right? So I can see what you're saying. I clean it up for other people to kind of make their own opinions. So let's move forward. Good job on that. So when we look at this, we know that the rate is a little tacky. We know that maybe it's a little irregular if we look from the R to R interval here versus the R to R interval there. The abnormalities, we can see some elevation, some depression for sure. We think we might have a little bit of elevation. So the question for this is it a STEMI? You lead to say that you think it is. We know for sure that this is everything we've already kind of said, right? The T waves are symmetrical. They have some rabbit ears, which is going to be here, which is going to be the R prime. But the thing that I want to key you on is what we talked about last week is ventricular hypertrophy. So with this patient, they actually have left ventricular hypertrophy. And so when we talk about that, that's going to be important because we want to see that if it's left ventricular hypertrophy, we want to take the sum of the tallest S wave or the lowest S wave combined between V1 through V3 combined with the tallest R wave in V4 through V6. And that's on last week's lecture. But let's just look at lead V2. We can see V2, when we go downwards, we can actually see that this tracing comes all the way down there. And so what we're going to do is we're going to count boxes. We need it to be greater than 35 to consider that it's going to be left ventricular hypertrophy. So it's going to be 5, 10, 15, 20, 25, 30, 35. Right there with one lead, I know they overlap. With one lead, we can tell that this patient has left ventricular hypertrophy. The definition was greater than 35 with the lowest S and the tallest R. So we don't have to go any further. This patient has left ventricular hypertrophy. And if you remember from last week, what I told you is if somebody has left ventricular hypertrophy, it's going to be very difficult to try to find anything else on the 12 lead besides an inferior wall MI. With the bundle branch block based on the QRS, that makes it even more difficult. So this patient actually is having a non-STEMI. This isn't a STEMI, but they still get worked up. All right, the STEMI will get the cath lab with the stents. The non-STEMI might be able to be managed with just medication. So when you see the non-STEMI, when you see this, obviously we have the left ventricular hypertrophy that's located here, but we can see that almost in the precordial leads, all the precordial leads, which is V1 through V6, we tend to have some sort of depression. And there's your depression here. This one's a little bit hard, but this is where the isoelectric line is, and this is where that is. So that's a little bit off. This is where it starts. This is here. This is where it starts, and this is here. So we have that depression. We really can't rule in or rule out an inferior wall MI there. So what can we almost diagnose it as? We can pretty much say that this is a non-STEMI. But that's why, you know, some of the things that we're building upon is important, because this is something true. So how we treated this is we treated it, the medics treated it for a STEMI, and you know, they still activated the cath lab. The patient, you know, came in and they got the treatments. They got 324 of aspirin. They got the 0.4 of nitro. Sublingually, we know that nitro paste isn't really that effective. If you want to learn about that, go back to the congestive heart failure. We talk about the different types of nitro. Oxygen with this patient, the oxygen was 93%. Because it's 93% and they're not short of breath, they don't get oxygen, right? We don't give oxygen to any vascular injury where the ESPO2 is not less than 90. So keep that in mind. And then obviously the 12 lead should be transmitted. So I know that some of the zone monitors cannot transmit effectively to some of the hospitals. You know, that's where apps like Pulsera or Triage will work great in those agencies, where you can actually take a picture of it and electronically send it. I know for us, and it's supposed to be over at St. E's as well, when you take a picture of that and you send it on Triage, or if you're in a different system and you use Pulsera, like in the Cleveland area, or maybe you're out of state and use something else, that the physician on call for that modality, whether it's cardiac, whether it's trauma, is supposed to see all the pictures. And at Trumbull, I know that our 2 interventional cardiologists who rotate days, they get it right to their phone. And so does the clinical nurse manager, and so does some of the on-call people. So they're going to get that. So if you can't transmit it via a modem, make sure you use an app and alternative method. All right. So this patient underwent and had a chronically obstructed RCA that led to the previous CABG. The distal RCA was fed from the left LAD. So the right side, the right coronary artery was fed from the left anterior descending via the bypass. The left anterior descending was also stented in the past. So that was where the 3 MIs came from. So poor cardiac perfusion. The right side of the heart was perfused by the left coronary artery. The patient was actually an AFib with RVR. And what they did is that caused the pain and the ischemia on the right ventricle. So the cardiologist slowed down the rates. They converted to normal sinus. They actually went for a cath to make sure everything was fine, and that's how they knew that. And then the patient was sent home on ditch and doing okay. All right. So I know we're 5 minutes over, but I think this is the last one. This is a real patient that was brought into our ER. 72-year-old female with chest pain, feels tired, mid-sternal epigastric pain. The skin is pale. Pain is for 6 hours. So again, you have your typical ACS symptoms. The differential diagnosis we've been looking all night. It could be pulmonary, it could be abdominal, gastro, it can be cardiac. All right. Extensive history for hypertension, COPD. This patient's obese and has high cholesterol. It's a smoker, on medication for blood pressure, heart rate, on diuretic, on a cholesterol medication, on albuterol. Vitals with this patient: blood pressure's fine, the heart rate's okay, the respiratory rate's okay, the SpO2 is 92%. Skin is pale, everything else looks fine. Of course, anytime there's a chest pain patient, EMT should take the 12 lead, transmit it to the hospital. That's in the protocol or in the state guidelines. And this is the 12 lead. So unlike the other 12 lead, we see that this patient clearly does not have the left ventricular hypertrophy. What's screaming out is we can see the here, here, and here. We can see all of these are elevated. So we can almost come to a conclusion right away by looking at it as it's a STEMI. And just a little side note, we've actually pushed our providers locally here at Trumbull. We want aspirin given on our chest pain patients within 3 minutes, and we want a 12 lead within 5 minutes. And so that's what we challenge all of our providers to do. And so we're QAing all of the charts that come through our medical command, whether they're going to other hospitals or not, but we're holding true to that because we need to improve these first medical contact to balloon times. And we have ours are actually pretty good when the patients come to Trumbull. But as a system, as a region, I think we can do better. The concept of let's get the patient to the ambulance and start treating is an old modality treatment. And, you know, maybe the scene is unsafe. Maybe that's why you have to do that, but that shouldn't be routine. And I've recently talked to providers where they said, you know, my theory and my medic or the medic I was working with just wanted to get the patient, walk them to the cot, do the 12 in the back of the ambulance, and then start treating the patient as they're going to the hospital. Aspirin prevents the clot from getting bigger, and nitro helps to perfuse the heart around that clot. So we need to actually, as providers, get out of that old school mentality of just, you know, doing whatever. Try to do things multi-step and do what we need to do. So by the time you've already taken that patient to the ambulance, you've wasted 5, 6, 7 minutes. And some cardiac centers, the cardiologist might be there, but the cath lab staff may not be there. So the sooner you can recognize the cardiac event, and it's good practice to transmit all cardiac events, whether it's STEMI, non-STEMI, you just don't know what's going on with it. Have that expert review it, either the doctor or the cardiology team, whether you're transmitting through LifeNet or you're transmitting through an app or taking a picture and sending it over to the ER. Try to do that because it's going to help the patient. And then if that patient's familiar with that ER or that ER is familiar with that patient, they can pull up old records. So what we might see might be alarming to us, but they might say, you know what, I looked at it, it's exactly the same. When I was in paramedic school, they did a 12 lead on me. And my instructor says, shit, you better go see a cardiologist. I'm like, okay, what did I know? I was just learning cardiology. So went to the cardiologist, went through a stress test. They maxed me out my heart rate. After I was done, they slowed me down and I felt I was going to pass out. So I got tunnel vision, I passed out, and I wake up and here's the crash card. I'm like, what happened? So here I just have an elevated J point. It looks like ST elevation in lead 3, but it's not. And so I know that I say, hey, let me look at that 12 lead. I know that it looks like I have a STEMI naturally in lead 3. And if you're just focusing on one lead, I'd have a cath lab activation anytime that I would have chest pain. So, but this patient clearly has ST elevation. All right. So what we would do is we would do everything we need to do, give the aspirin, give the nitro. And now, you know, we're not giving fentanyl anymore. We're switching to the Tylenol, and in the systems who are giving Brilinta and heparin, that's great to help, you know, preserve heart tissue. All right. So I know the end of this was kind of rushed simply due to time, but I think everybody who's been kind of staying on with us, these real life scenarios are definitely interesting, and you know, I think we can learn from other people, and we can definitely learn from our peers and what works best, and learn from it, because what you're thinking, somebody else is probably thinking it. But to those who stepped up and participated tonight in all the lectures, I want to thank you. And that's what makes it, you know, tailored to you. And again, this isn't just us lecturing to you. We want to be able to present information that you're going to take back. Whether you're an ALS engine responding in a township or a city or a village waiting for a transporting crew, whether you're a private ambulance, whether you're a fire department ambulance, whether you're a county-based ambulance, you know, we can all do better as a whole, and we need to do that in order to grow the profession. So that's where my passion is, and hopefully I've inspired and can share my knowledge with you guys. So with that, does anybody have any questions? All right, I see we lost 18 people, but that's okay. All right, well, thank you very much.
Well, thanks, Larry, man. That, as always, that was good. I learned a lot today from all 3 speakers. I gotta be honest with you. I learned a lot. I learned some good tips. I learned a few things I didn't know and reminded of a few things I forgot. So I appreciate everybody that came in tonight. I want to thank everybody else for coming and hanging out a few extra minutes with us. Without any further ado, we'll let you go. Are there any questions out there? Ooh, they have a working fire in Hubbard. I'll be there in a minute.
I'm sure Mike Cake's already there.
All right, everybody. Good night. It was an absolute pleasure. Do you have a question, Mr. Bizzle?
No, just put my hand up, say goodbye.
Just put his hand up, say goodbye. Okay.